السلام عليكم. ألو. على اليوتيوب. أيوه.
فون مقصودة ولا كيف؟ لا بس البوينتر ايه لا شغال
الشاشة فيها دورة لا تمام زي الباور. طيب هذا ما لما نشغله بيطفي جنب الحمل. لا لا ثابت المفروض نشتغل. طيب الحين كيف؟ هي شغال الحين شيء لا
الساعة كم؟ 47. شو الخطأ اللي يجي طلع التسليم هذا في بكرة هيستوعب على كان هذا واحد يتكلم، هذا واحد يتكلم.
النظارات العامة
إيه؟
النظارات كلها بس
كل هذا
هذا لا ما عاد بالصفر. مو الديني شيء اللي عليه وزن ده اي 5 شيء اللي عليه وزن ده بي 5 inbox 5 لا في اس اس هو 5 اس وكنا 5 سجلت صح اس شوف شغلنا ميزه شغال خلاص أول السؤال أول شيء.
طيب، بسم الله الرحمن الرحيم، والصلاة والسلام على رسول الله. صباح الخير عليكم جميعا. It's my pleasure to announce the kick-off of our conference. It's the Hajj Medical Conference for this year. And our agenda is broad and it's extensive, and it's covering the most acute medical and surgical emergencies. And actually, we designed the agenda of this conference to be cover the most important topics. And tomorrow, inshallah, we have a separate topic to discuss the most IE or infectious disease during the Hajj. And it's important to mention that our opening ceremony, it will be tomorrow at 8 a.m. exactly. And we will start today with the first session. It's acute surgical emergency. And for 2 days, actually, the lunch will be provided at the swimming pool. And for the first session today, it will be moderated by Dr. Fadil al-Zahrani. He's a general consultant surgery, and also he's a consultant of EI and bariatric surgery. He is a member of American College of Surgeons. As well, he is the program director of the general surgery residency program at Makkah Health Cluster. Welcome to Dr. Fadil, and we are lucky to have you today. And you will moderate the first session. And now the floor is yours, Dr. Fadil.
We'll start with the speaker and define the product. He is a very fantastic surgery specialist, head of hospital emergency planning preparedness here in the Nor. He's tasked with emergency plan
هذه كلها في الاثنين مع بعض.
تتحرك هذه الموبايل هذه ولا فيكس؟ موبايل ولا فيكس؟ بس شغال المحاضرة؟
بس كذا من هذا ما قاش عندنا.
شغال؟
شايف ما كان زمان.
مو شغال الحين، شغال فيه؟ ما في ذاك.
ايوه بسم
الله. بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. واضح؟ هذا واضح خلاص؟ بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good morning everyone. Thank you for all attending. شكرا Dr. Ayman. Welcome to all my friends. We'll start about our emergency plan in Noor Hospital. We'll speak about our objective, definition, codes, internal disaster, external disaster, role responsibility, and triage applying teams. Our objective in our plan to coordinate the effort in Noor Specialist Hospital in the event of disaster and quickly restore the facility in the same operation capability as the pre-disaster level. You have common language in all hospitals to provide guidance, personnel through detailed instruction, define the role and responsibility for all hospitals, a quick call-up system in order to notify all off-duty staff members, properly utilize the resource, and establish coordinated protocol with the local authorized concerning. About definition, we'll speak about disaster. What is the disaster? It is a sudden unplanned event that makes it difficult or impossible for a facility to carry out essential activity. We have two types of disaster, external and internal disaster. External disaster, we'll speak about something out your institute, out your hospital, like some building collapse, fire outside, like crash bus is outside. Inside your institute will be internal disaster. Will be something inside your hospital like fire, like for example, if in utilized problem, if in they have chemical hazard village and they have anything bomb block, for example. Regarding the code, we have 10 codes now approved by Saudi Medical Council. This is code approved in all hospitals, governmental, non-governmental, MOH, non-MOH, all this code. Before there is some hospital, it has special code. Now we have 10 codes fixed in all hospitals. First, code red. Code red will speak about some internal disaster regarding fire. Before, the code red was related about trauma outside, about more than 30% outside in the casualty outside. Now, code red will say only for internal disaster. We have 3 levels from code red: standby and active, and in the last clear after finish the disaster. 3 levels from the code red. The second code will be external disaster, will be code yellow. Code yellow, any outside disaster like a crash bus, for example, building collapse, fire outside will be code yellow. Even for the code yellow, we have 3 levels: standby and active and clear. Code black. This is from a new code. Code black, we talk about bomb threatening outside. Also, there is 3 levels from this code black: standby and active and all clear. Code gray. This is related to the weather, severe weather. We have 3 levels: standby and active and all clear. Code blue. This is all code, but now we have 3 levels for this code. Standby will be replaced, inshallah, nearly for rapid response team, and active and clear. Code orange, this is related to chemical hazard or biological hazard outside, will be, this is only 2 levels, active and clear. Code brown, you'll talk about something inside your hospital like utilized failure, electricity problem, IT problem. This will be inside the hospital, will be 2 level also, active and clear. Code silver, this is somebody attacking you with a weapon. Okay, will be 2 level, active and clear. Code pink, this is all code, talk about child abduction, active and clear only. Code white, this is somebody attacking you without a weapon. واحد اعتدى عليك لفظي او لا قدر الله بيده زي كده without a weapon. This is the code, 10 codes we have it in the hospital and all hospital in the kingdom. And we have royal order for extension, this for code blue only. This is the extension in all hospital in the kingdom, 2222. If you have code blue in the hospital, you should call in the extension 222. Other code in the hospital will be our extension 777. This is fixed in all the hospital. This is by English. Speak about the external disaster. What is the rule? Rescue the patient from the immediate dangerous to assembly point. Break the glass to fire alarm box. Dial 777 in calm and announce the location of the fire 3 times. Confine the fire by closing the window and door. Don't fight alone. If you have 2 persons, should be start to fight. If you are alone, don't fight. The department is located to assembly point in the floor will be decided by HIPPO staff team on duty or medical coordinator on duty in each floor. This is very important for us, race concept for all the hospital. You should know the all employee race. When you have the fire in the hospital, you start about R. R, rescue the patient. إنقاذ المريض، إخلاء المريض من مكان الحدث إلى مكان آمن. A, alarm, activate the alarm. You have the way how to activate the alarm. Call the extension 777, open the fire or break the fire alarm box to start to activate the alarm. C, contain the fire. By after evacuation the room, you close the room, close the window, and keep below the door, some beneath the blanket or bed sheet. E, extinguisher, how to use the extinguisher should be known. All the staff should be known how to use the extinguisher. The goal is very important for us is life safety. The primary goal for fire safety is to protect building occupants from the injury and prevent the loss of fire, property protection of the operation. This is the fire alarm box. Rescue the patient is very important. Activate the alarm. After that, confine the fire. E, extinguisher and evacuation. How to use the extinguisher? Pull the pin and squeeze it and sweep it. How to use the طفايات الحريق. This is the type of the fire extinguisher you have it. This is the hospital mapping. You know, in designing the hospital, in all hospital we have fire zone. This is the fire zone like this. You know, yellow. This is fire zone. This is red fire zone, black fire zone. If you have fire, if you close the area, inshallah, bismillah, the fire will not be extended for other zones. And this is the map in everywhere in the hospital. You have the map. Where are you? And what is your emergency exit beside you? Where is the fire alarm box? How to activate it? You should know it. Where are you? And what is your place and what is your emergency exit? In the list of sequence during the fire, first call from the shard. Anyone discover the fire? Shard nurse, anyone discover the fire should dial 777 and now code red, standby or active, and give the location 3 times. The second call from the operator, he will call the responsible teams. Third call, the hospital director, CO, or the who's on call, he will announce, informing through the wireless station. There is code red in النور hospital and cannot control and we need help. This is for evacuation. We should know regarding evacuation. Our evacuation from up to down. The most of evacuation from up to down during the fire. You should move first the mobile patient. After that, wheelchair. After that, patient in the bed or patient in the stretcher. Never use elevator during evacuation. Never leave the patient alone. Okay. The first, during fire, just evacuate the patient from the fire site to the safe area, away from the fire in the same floor. Don't go for horizontal evacuation. Just vertical evacuation. Leave it for the higher authorized version. Bring the patient medical file is very important. Remove the gas cylinder from the fire tank. Have a system to attacking the room. Patient need wheelchair, cover with the blanket and send it. Severely ill patient should be carried out by trolley or pulled on the ground to be sure all the patients evacuated in the room. Check the bathroom. There is nobody inside the bathroom. There is special evacuation special for ICU, CCU burn patient because it's very difficult. As I mentioned, there is rule and responsibility for everyone in the hospital, from CEO till the worker. Everyone he has rule, and everyone should be know what his rule. Rule of the doctor: organize the evacuation patient, structure the way of transferring the patient, instruction to facility to evacuate the patient, check, observe, organize all staff in the proper place and the proper action taking, check all members of the holding area directed in the holding area, follow the instruction of the leader. As I mentioned, this is rule and responsibility for everyone in the hospital. He has rule. We'll speak about external disaster. The general rule of staffing during disaster: checking all the team in place with all facility, distribute staff according to situation need, coordinate with other subspecialty, evacuate all bed in the ER with supervision of the director of ER, ensure quick dispatching flying team members to call necessary staff to support during disaster, ensure safety during transferring patient to allocated ward, daycare unit, and all the ICU can be opened during disaster to receive evacuated patient from ER. And this is the authorized leader order at times. A transfer stable patient to their ward, coordinate with the concern, admit the patient in their respective ward, coordinate with their respective consultant for patient who need urgent surgical intervention, receive all stable patient from ICU to other department, help transferring stable patient, receive all admitted patient in the department, and do all the necessary medical management. Right. This is the general step. I will pass it quickly about during the code, how to receive the notification through the wireless station from the operation room in Mecca. This is, I will pass it quickly. Rule and responsibility. This is the rule and responsibility for everyone. It's very important for us a triage area. This is in the main gate of the ER, will be by ER head group leader. It's very important area. This is the distribution of the doctor in the area and they are the general rule during pharmacy, radiology, laboratory, nursing office, security. Everyone has the rule. Medical record. You have disaster record during the external disaster. Start by number 9. This open file. Social worker has rule. Kitchen has rule. Laundry department. Triage. Very important about triage. This is the main gate of the main gate of the ER. This is the area screening the patient to evaluate, categorize the severity of illness of the patient. You have many types of triage. This is red for critical patient, and this is yellow for patient he can wait stable, can wait for a little time, and this is the green, and this is the black for patient. This is the universal code. This is triage algorithm. You have many triage algorithms. This is very easy algorithm for triaging the patient. This is start algorithm. This is for child, and this is for burn victim, how to evaluate the patient. The critical patient more than 15. Yellow patient from 5 to 15, less than 5 will be green, minor. This is the triage card. We have it in our now triage. This is in the after triaging the patient, we'll keep the patient with this card and we'll cut the last part. If the patient is yellow, we'll keep the last thing is yellow. If the patient is red, we'll keep the last thing is red. This is the holding area, doctor, and we'll pass about the flying team. The hospital will have mandatory to dispatching the flying team when needed. Flying team A, a flying team B, flying team C. The flying team A will be one doctor from orthopedic and one from ENT and two nurses. And the flying team B will be 2 ambulance. The flying team C will be 1 coaster past 25 seats. The rural flying team, all the flying team, nurse and doctor will respond immediately to the call in the reporting. They are within 5 minutes. The emergency bag, the site is already available and checked daily by responsible team. Follow the instruction of order of emergency crisis administrator in Mecca. The principle of triaging the patient, preserve the life, prevent deterioration before more definitive treatment. The team leader will be given instruction to the nurse. This is the extension for, or this is the wireless codes for the responsible teams in Mecca during through the wireless station. For example, Dr. Hatim Al-Umari, this is the head of the OC of the cluster, will be named in the wireless station Sahi 1. Dr. Abdul Rahman Ghafouri, he's the director of the okay, Saham 1. For our hospital, our leader is called Dr. Al-Maimini, CEO is Shifa 111, Shifa 11. Dr. Ahmed Al-Sawi, Shifa 12. Our Noor hospital in the wireless station is called Shifa 1. This is the code of the cases through wireless station. For example, if you have fire, in code حالة رقم 2. For example, if patient has crash bus حالة رقم 4. انقلاب سيارة حالة رقم 6. Our message in the last feeling preparing for disaster is disaster itself. Sorry.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. First of all, I would like to thank the organizing committee for giving me the opportunity to be participating in this conference. And thank you, Mr. Chairman, for your introductions. Our lecture today is a traumatic brain injury. We'll speak about the lectures in terms of epidemiology, pathophysiology, anatomy, classification, surgical management, guideline, and complications and outcome. Regarding the epidemiology of the traumatic brain injury, of course, traumatic brain injury is the major cause of morbidity and mortality in developing and non-developed country. These are statistics taken from the state. There is about 2.5 million per year of accidents in the state, about 250,000 who's been hospitalized, and about 50,000 died. The statistic I found in Saudi Arabia, it's coming from the Saudi Traffic Department's statistic. It was in 1439. The number of accidents was about 30,000 accidents. 6,000 died during these accidents. 50% died due to traumatic brain injury. 80% of these accidents are mild, 10% are moderate, 10% of traumatic brain injury being severe injury, and male to female ratio is 2:1. The causes of these injuries, road traffic accidents take the major part, 45%, for about 26%, assaults and gunshot about 16%, and sport about 12%. Going through quickly the anatomy, you know that the head has been divided into skull, meninges, brain, cerebrospinal fluid, and tentorium. And each of these subdivisions can can have injuries and the patients can suffer from the sequelae of these injuries. In the scalp, as the state of the letters consists of skin, connective tissue, aponeurosis, lows, irregular tissues, and pericranium. We are more concerned about the bleeding coming from the from scalp lacerations because scalps has a rich blood supply, and in children they can lose a lot of blood if they have injury to that area. The skull, as you know, it's been divided into a frontal lobe, frontal bone, and underneath it the frontal lobe parietal, and underneath it the parietal lobe occipital, and underneath it the occipital lobe. And we have three anterior, middle, and posterior fossa. In the anterior fossa, the frontal lobe subside, middle, the temporal lobe subside, and the posterior fossa, the brain stem and the cerebellum. The meninges are divided into the dura, the arachnoid, the pia. Between the subdural space, there is a potential space exists in the subdura, so the blood and the hemorrhage can occur in that area. And of course, the area where the cerebrospinal fluid circulates between the arachnoid and the pia, where subarachnoid hemorrhage can occur. The brain consists of the frontal lobe, parietal lobe, temporal lobe, and occipital lobe, and the cerebellum, and the brain stem consists of the midbrain, bones, and the medulla, and each part of these can have injury during brain injuries. The pathophysiology, usually we divide the injury to the brain into primary injury, which is the insult itself, whether is it related to road traffic accidents or any other cause of injury. So the primary result of that, whether in terms of fractures, contusions, hematoma, diffuse axonal injuries, or others, is considered to be the primary injury to the brain. The secondary injury, which we have to consider more, because as a physicians, we can avoid these secondary injury and prevent further injury to the brain. These include hypoxia, hypotension, high ICP, electrolyte imbalance, metabolic imbalance, coagulopathy, edema, ischemia. If we try to do that, we'll prevent the herniation, which causes most of the mortality to the patients. This herniation can occur through the central part of the brain, subfalcine during the two hemispheres of the brain, ankle herniations where there is a hematoma or injury due to the temporal lobe, or tonsillar herniation to the posterior fossa. Usually the edema which occurs in the brain usually is the cytotoxic edema, which is different from the edema which occurs in other pathology to the brain, such as infection or vasogenic edema. We have to mention the cerebral blood flow. The cerebral blood flow is approximately 50 mL per 100 milligrams of the brain. Usually we have to maintain the cerebral flow, because if cerebral flow goes beyond 20 mL, the ECG changes will occur, and if it is less than 5, cell death can occur. The brain is characterized by a phenomena called autoregulations. Autoregulations is the maintain the cerebral blood flow between the mean pressures of 50 to 160. These are the area where the brain can accommodate the changes in the blood flow without causing any problems. If it is going beyond or below that, there will be some severe disturbance to the blood flow. Since 1793, this Monroe Cayley Decrane described that the cranium is a rigid box, and its volume has been being constant: 80% brain, 10% blood vessels, 10% cerebrospinal fluid. So if one component increases, it will occur in expense of the other components. So if there is a mass lesions, it will cause problems in the cerebral blood flow and the blood volumes, and that will change the mechanism of cerebral perfusion pressures. And at certain point, this can be reversed and compensated. But if the volume increase, the cerebral blood flow will be reduced, the ICP will increase, and autoregulation will be lost, and this can be results in an uncompensated mechanism, and irreversible changes. Intracranial pressures is a measure that we use in cases of severe head injury. Normal intracranial pressure is about 10, abnormal when it reaches 20, and severe when it reaches 40. Cerebral perfusion pressures is the thing is that the ICU consultants can help in maintaining perfusion to the brain when you have an intracerebral pressure monitoring. So you can manage the intracerebral pressures or maintain the mean arterial pressure so that the perfusion pressure will be more than 70. If it goes beyond 70, it will cause harm to the patients. So the classifications of head injuries can be different according to the mechanism of injury, severity of injury, or morphology of the injury. Classifications can be due to the blunt injury to the brain. If you go to the morphology, either by high velocity or motor traffic accidents, or due to low velocity such as fall or assault. Mechanism of injury can be penetrating or non-penetrating, gunshot, or other causes of sharp objects. And when it comes to the severity, we have the Glasgow Coma Scale, which indicate the severity of the injury. Mild injury for between 14 to 15, moderate between 9 to 13, and severe below 8. This is a Glasgow Coma Scale. It's been applied to all head injury patients. It has 3 components: the eye component, the motor component, and the verbal components, and each of one has been subdivided. The issues of Glasgow Coma Scale is that it's a tool to know the initial state of the patients, and more importantly, as a follow-up of the patients, whether in the ICU or on the floor. When it comes to the morphology, we start with the skull. The skull fractures can be in the vault or in the basilar base of the skull. Intracranial lesions such as epidural, subdural, intracerebral, or diffuse as mild concussions, or classical concussion or diffuse axonal injury. Come to the skull fractures. The significance of the skull fracture should be not be underestimated, since it takes a considerable force to fracture the skull. Linear fractures is the risk. There is a risk of intracranial hematoma in about 40% in a conscious patient and 20% in comatose patients. Open and compound skull fractures require early surgical intervention. Basal skull fractures require CT scan with a bone window. The presence of the classical signs of skull fracture should be known by most of the ICU and most of the people dealing with the trauma in the emergency room. Periorbital ecchymosis called raccoon eye, retroorbital ecchymosis called butter signs. CSF leak is an indication of basal skull fractures. 7th cranial nerve is one of the commonest nerve to be affected, especially in comatose patients. This is a typical of raccoon eye. They have skull-based fractures. This is the CSF leak, and usually the CSF leak in most of the patients subside in 2-3 days, but sometimes it remains up to 7 days occasionally. If it is mild, it's fine. If it is continuous and diffuse, you have to put the lumbar drain. This is a periocular ecchymosis, which is considered as a better sign, and it's a sign of basal skull fractures. The breast skull fractures is the fractures when there is a degree of depression greater than the thickness of the adjacent skull. This indicates that this fractures has to be elevated surgically. Non-displaced skull fractures can be managed conservatively. This is what we meant. The full thickness of the skull is being depressed, and you need to elevate this surgically. Intracranial lesion can be classified as focal or diffuse, although the two forms can be coexist together. Diffuse brain injury is the most common type of head injury. It represents a continuum of brain damage. produced by increased amount of acceleration, deceleration injury. In general, some of these patients, in spite of their normal CT scan, they've been comatose, and that indicates the severity of injury, and you need MRI to diagnose this patient. Based on the depth and the duration of coma, the diffuse injuries can be classified as mild concussion, classical concussion, diffuse axonal injury. The difference between mild concussion is that there is no loss of consciousness on this mild concussion. It's just basically a degree of temporary neurological dysfunctions. It's a mild degree, and it is a modest degree of cerebral concussion, usually without amnesia or loss of memory. But the classical cerebral concussion is where the loss of consciousness, the variability of level loss of consciousness can be from 1 minute to five to more than that, and it is measured the severity of the injury. Many patients of cerebral concussion have no sequelae to the problems except amnesia, and some of them, they may have difficulty after that for memory deficit and depression. Diffuse axonal injury is the most severe forms of this injuries. Usually, patients prolonged post-traumatic coma due to the mass lesion, or due to the not due to the mass lesion or ischemic insults. Patients are deeply comatose, often demonstrate evidence of decortication and deceleration, and often remain severely disabled. These patients have also autonomic dysfunctions such as hypertension and hyperpyrexia. These are typical pictures of what we call the salt and pepper appearance of diffuse axonal injury. It's typically around the corpus callosum, either anterior or posterior, and you find these scattered areas of diffuse axonal injury where the axon is being cut and the patients render comatose. For the focal intracerebral lesions, either due to the venous bleeding or arterial bleeding, venous usually slow, arterial, of course, it will be faster. The most common type of this is an epidural hematoma. This is a potential space between the dura and the cranium, and referred as extradural. This is caused by blow to the head and interruptions of the vessel, especially the middle cerebral artery, or could be the vein or the dural vein or the dural venous sinuses and skull vessels. It's a typical shape of this epidural hematoma, included in different area of the brain. Usually, it's about 10 to 20% of patients of head trauma, and 70% of previously conscious patients can develop later on epidural hematoma. In traumatic epidural hematoma usually forms extreme force within 10 to 20 minutes after injury. The patients initially present with head injury and scalp lacerations, encephal hematoma, and contusion. Most of the patients with epidural hematoma, the location is temporal or temporoparietal. The patients with epidural hematoma typically have episode of regaining consciousness, and then later on loss of the consciousness. This phenomenon is very characteristic of epidural hematoma. It occurs in about 20 to 50% of the cases, and it's called the talk and die patient. The reason of that is that the hematoma initially becomes small. Patients goes unnoticed and regain the consciousness. Later on, when the hematoma becomes severe, the patients lost the consciousness and then go into coma. The severe intracerebral epidural hematoma can cause what's called Cushing triad. Cushing triad consists of hypertension, bradycardia, and respiratory depression, which indicate that you have to take the patients to ER immediately to evacuate this. And usually this one is reversible. This is a typical CT scan with the other picture that we saw. It's an lenticular shape, biconcave. And we have lectures on this at the end of this session for the X-rays of different type of injuries. Conservative treatments for acute epidural hematoma, usually for smaller epidural hematoma with no mass effect. This is can be treated conservatively. If it is If it is higher, the greater than 30% thickness is 15 and midline shift, you have to take the patients to OR and evacuate it. The hematoma. This is a hematoma with the vesical fractures underneath. The subdural hematoma, usually more common, occurs in the space underneath the dura. Normally cover the entire surface of the dura. Patients with a subdural hematoma can be acute, subacute, or chronic. Acute is less than 72 hours. Subacute 3 to 20 days. Chronic more than 20 days. Clinically, the patients have altered level of consciousness, dilated pupil on the same side, and contralateral hemiparesis on the other side. This is a typical of acute subdural hematoma involving the right side. Management usually surgically consists of large craniotomy and evacuations of the hematoma and elevating the compression of the brain. And if it is a chronic and the chronicity is more than 20 days, it can be done by fair hold. This is a typical of acute. This is a typical of chronic. Sometimes the chronic subdural hematoma develop membranes, and you have to take these membranes until you reach to the brain. These are typical contusions in the brain, usually treated conservatively with no surgical intervention. Subarachnoid hemorrhage is the commonest cause, usually associated with all others. These are typical subarachnoid spaces. Subarachnoid hemorrhage, and if it is isolated, has no problems, but sometimes patients develop hydrocephalus in later stage. Intracerebral hematoma, not very common in head injury, but if it is in a critical area that like the posterior fossa, you have to evacuate it. There is a guideline that has been developed by the American Association of Neurological Surgeons in 2017. This included these items: ventilation therapy, ICP monitor, CSF drainage, CSF cerebral perfusion pressure monitoring, hyperosmolar therapy, steroid, infection, DVT prophylaxis, nutrition, prophylactic hypothermia, barbiturate, and decompressive craniectomy. Tomorrow you have the second lectures about the ICU managements of head trauma, and you will have all this been discussed in detail. So if you have a management of intracerebral hypertension, you elevate the head of patients, avoid neck restrictions, avoid hypoxia and hypotension, central control hypertension, sedation, CSF drainage, hyperosmolar therapy, hyperventilation. Second tiers, you can use hypothermia, hyperventilate more. You can go to barbiturate coma and decompressive craniectomy. Complication of traumatic brain injury, including cognitive impairments, CSF leak, meningitis, cranial nerve palsies, vascular injury, seizures, hydrocephalus, and psychological developments. Outcome score for the patients with head injury. There is a good outcome. There is bad outcome. Most of the patients with severe head injuries, they are in the second persistent vegetative state, which we have a lot of them after severe head injury. Prognosis depends on the extent. If it is mild, you have good prognosis. Moderate, you have mild disability. Severity, about 5% become vegetative. Rest of them, they have some recovery to good recovery. These are new therapies, and especially calcium blockers are being now in use in ICU for some of the head injury patients. The home message for the lecture is that prevention is the best treatments for head injury. Once the injury is being done, the recovery is not as we expect. Thank you very much.
session. Today we'll talk about approach and use of ARDS, which is a very common topic in ICU and the most leading cause of this during the COVID pandemic period. The first definition for ARDS is a medical consistent definition, which is published in 1994. They are saying appropriate clinical setting of acute onset, B ratio less than 200 for ARDS in acute lung injury between 200 to 300, bilateral chest X-ray infiltrate with no evidence of left atrial hypertension. The problem with the definition is there is was there unknown considerations in the definition. Okay, so the definition updated in Berlin to 2012 is containing 4 criteria: timing, chest imaging, and origin of pulmonary edema, oxygenation severity. The first criteria, timing, less than 1 week of non-clinical insult or new worsening of respiratory symptoms, chest imaging, bilateral not fully explained by effusion, atelectasis or nodules, origin of edema not fully explained by cardiac fluid overload. If no ARDS risk factor, we need objective assessment. Oxygenation severity, there is a mild, moderate, and severe ARDS. Mild ARDS, FPF ratio between 200 to 300, moderate FPF ratio between 100 to 200, and severe FPF ratio less than 100. Major difference between the both definition: acute lung injury is eliminated. Now we have mild, moderate, and severe ARDS. In the previous definition, we need wedge pressure to rule out cardiac cause for ARDS. Now we need clinical assessment. Berlin definition is including CPAP or beep more than 5. This is an example of chest X-ray for a patient with ARDS. We can see bilateral chest infiltrate, endotracheal tube, and infiltrate in both lungs. So the history of ARDS. First published data about ARDS was during Vietnam War by Ashbach, published in Lancet 1967. They said the respiratory distress syndrome in 12 patients was manifested by acute onset of tachypnea, hypoxia, loss of lung compliance after variety of stimuli. The syndrome did not respond to usual ordinary method of respiratory therapy. So this is an epidemiology of ARDS. We can see the incidence per 100,000 person per year is around 0.8. For acute lung injury. For ARDS is around 0.6%. The mortality of ARDS in acute lung injury is 38%. For acute ARDS is 41%. So the most important thing to manage and to approach to the patient with ARDS is to know the pathophysiology and pathology of ARDS. Usually we will have a trigger either from pneumonia directly to the chest or from sepsis from other source in the body that will cause cellular chemical mediator release, that will cause alveolar capillary injury, will cause syndrome characterized by permeability edema, abnormal surfactant, and capillary thrombi. Will cause stiff lung, muscle fatigue, shunt, hypoxia, pulmonary hypertension. So this is an example for a trigger, usually primary trigger, direct lung injury, either from aspiration, pneumonia, bacterial or viral pneumonia, like COVID, contusion to the lung, inhalation injury, will cause patchy infiltrate in the lung, usually less beep responsive. It doesn't evolve to SARS or multi-organ dysfunction syndrome, the outcome better than secondary ARDS. Secondary ARDS, the lung is one of many organs involved in the SARS or multi-organ dysfunction syndrome, like sepsis, pancreatitis, hypotension, or burn. Usually the X-ray will be diffuse with more beep responsive. the outcome worse than the primary ARDS. So this is a risk factor developing ARDS. We can see sepsis, aspiration pneumonia, overdose, transfusion, fracture, or contusion. All this can cause ARDS. So here we can see an example of normal alveoli, usually clear and clean. This is the alveoli for a patient with ARDS. We can see interleukin release, macrophage, and widening of interstitial microthrombi in the capillary. So ARDS is very complicated syndrome caused by many stimuli evolved to the lung. Here we can see pulmonary injury sequence, endothelial injury, damage, alveolar cell injury or loss, capillary congestion, interstitium edema, protein accumulation, surfactant deactivation, atelectasis, hyaline membrane formation, inflammatory cell migration. Many physiology and pathophysiology evolved to the lung during ARDS. ARDS clinical progression, stage 1 usually initiation at the trigger, X-ray usually normal. Pathophysiology will have polymorphoneutrophils. Stage 2 between 1 to 2 days, the X-ray will start to be patchy. The lung will be edematous, type 1 cell damage. Stage 3 between 2 to 10 days, the X-ray will be diffuse, infiltrate, exudative type 2 proliferation, and stage 4 after 10 days, the X-ray will be diffuse, lymphocyte and fibrosis will be developed. So acute alveolar injury, exudative phase, vascular lesion, fibroproliferative phase. So ARDS management based on the pathophysiology. Here, usually we'll have a trigger, as we mentioned. The trigger will cause cellular and chemical mediator release. Here, we will try to block the initial sequence after the trigger. How we will do that? By giving the antibiotic and source control. Like if we have a patient with diabetic food, with the infection, usually we'll control the source. We remove the infected device. Like UTI, if the patient having Foley's catheter with UTI, we remove the source and start antibiotic. Prevention is very important step to block the trigger from causing ARDS, reduce the aspiration risk, prompt resuscitation, minimize transfusion or TRALI. So the second step of management is blocking the mediator activity after developing the cellular and chemical mediator to avoid alveolar capillary injury. How we'll do that? There is many study done on this area in coagulation cascade to avoid and treat microthrombi, steroid use, immunonutrition. Most of the study was failed. Lastly, there is a study published in 2020 in Lancet about using dexamethasone in ARDS. It showed mortality difference in 60 days mortality. The mortality by using dexamethasone is around 21% versus 36% in control groups. The dexamethasone was used for a total of around 10 days or until extubation. Here we can see the dexamethasone reduced duration of mechanical ventilation, overall mortality in patients with established moderate severe ARDS. But still is not a guideline to treat a patient with dexamethasone. This study is done for 277 patients. There is a risk and complication with the steroid. Because of that, still not a guideline to treat a patient with ARDS. The second step in managing patient with ARDS is to minimize the complication and block the manifestation. So how we will do that? By is the goal of management of ARDS is to pay a time. So usually we will have a trigger. The lung is injured. So it's like any wound or injury in the body. So we'll try to avoid complication and pay time to give a time to the lung to heal. So the problem with the lung is transmitting the oxygen from air to the body. So still we need to use the lung. So how we'll do that? By support gas exchange during ARDS, lung protective ventilator strategy, altering fluid status in the body, assure component of oxygen delivery, other things like nutrition, infection prevention, DVT prophylaxis. So this is one of the very famous and most famous study in ARDS, which is called ARDS Network Study, published in 2000. using the protective lung strategy versus control group protective lung strategy, tidal volume 4 to 6 ml versus control group 10 to 12 ml per ideal body weight. So what's the result of that study? It changed the clinical practice to ventilate the patient with ARDS. So in this study, they give 4 to 6 ml per ideal body weight tidal volume. That study, conventional group 10 to 12 ml. The mortality in protective lung group is 31% versus around 40% in conventional group with the 10 to 12 ml per ideal body weight tidal volume. So here we can see the mortality, as we mentioned, 31 to 40 day of free mechanical ventilator, 12 versus 10 in high tidal volume, day of free of organ failure, 15 versus 12, and the p-value is significant in all group. So here the lung protective ventilator strategy is to ventilate the patient above the lower inflection point and below the upper inflection point. So to avoid volutrauma, we avoid high pressure and high tidal volume. To avoid atelectotrauma, we provide beep and we try to ventilate the patient above this area. So here we can see this is the safe area to ventilate. This is dangerous area and this is dangerous area. So this is a dynamic CT for a patient with ARDS. This is during expiration. We can see if we ventilate the patient below the lower inflection point, there is a lot of atelectasis. If we ventilate the patient above the upper inflection point, there is overextension of the alveoli that will cause more release of the cytokines and more damage to the alveoli. So both area should be avoided. So this study is not just the low tidal volume, it's more than that. So use of predicted body weight to ventilate the patient, maintain plateau pressure, less than 30, respiratory rate titrated to maintain a pH 7.3, appropriate combination of FiO2 and beep to achieve PO2 between 55 and 80, and to make the saturation above 88. So this is another study in ARDS. As we know, the lung usually like to be dry and to give you good function. The kidney like to be wet. We have to be in balance between the kidney and the lung during the ARDS. So this study compared both group conservative versus liberal group fluid measure. So it showed conservative fluid strategy management improve lung function, shorten the duration of mechanical ventilation and intensive care without increase in non-pulmonary failure. So keeping patient dry is lead to good function of the lung. So other study comparing liberal versus conservative blood transfusion during ARDS, it show conservative blood transfusion targeting or accepting hemoglobin of 8 will give you a better result and mortality in ARDS. This is other study for neuromuscular blockade. It's called Accuracy, published in 2010. The group of muscle relaxant cisatricorium for 48 hours showed the mortality of 31% versus placebo 40%. This is other study published in 2019. It's called ROSE, show giving the continuous infusion of muscle relaxant show no difference in the mortality. So the recommendation is to use muscle relaxant as a BRN or for shortened duration, not for 48 hours, because there is no difference in mortality. There is many things we can use if patient is still hypoxic, like a bronch position, inhaled nitric oxide, ECMO, high frequency oscillator. So high frequency oscillator is now out of game since 2013 because of OSCAR and OSCILLATE. OSCAR show increase in mortality when we use high frequency, and OSCAR show no difference in mortality if we use high frequency compared to conventional group. Now high frequency is becoming as a risk management. We can use it if bronch position and ECMO are contraindicated or unavailable. This is a bronch position in a standard bed. This is a bronch position in electro-bronch bed. So bronch idea started since 2001. till 2013, many study and trial failed, but in 2013, the study success and show mortality difference 23% in bronze group versus 41% in non-bronze group. So the secret is making the patient in a bronze position for longer duration, 17 hours per day, to improve the gas exchange. So here, the both group of bronze and supine group. So this is ECMO. ECMO, we have veno-arterial ECMO or veno-venous ECMO. This is veno-venous ECMO. We take the blood from the vein, we oxygenate it, we remove the CO2, we return it back to the body. Caesar trial published in 2009 show significant difference in mortality, 24% in ECMO group versus 53% in non-ECMO group. EOLA published in 2018 again is downgrade the ECMO from standard of care in managing patient of ARDS to be a risk therapy. So if we fail conventional mechanical ventilator group. So remember ABCDEFG when you are treating patient with ARDS. A, to maintain the airway, insert the tube if needed. B, breathing, mechanical ventilation, oxygenation, and elimination of CO2. C, for circulation. D, diagnosis, find the underlying problem and control the source. E, empirical antibiotic when is needed. Feed the gut to avoid bacterial translocation. So ARDS mortality over the last 2 decades start to improve. Here we can see the ARDS till now mortality is around 40% without multi-organ failure. If with multi-organ failure, so the mortality is still around 80%. So mortality in ARDS not only in ICU. This is the mortality outside the hospital and ICU for 1 year. Still patient with ARDS is carrying mortality up to 11%. His 6-minute walk test, vital capacity, DLCO will not be normal as any other patient. So again, remember the pathophysiology of ARDS, approach to therapy based on the pathophysiology, treatment overall physiological strategy, reduce shunt fraction by tidal volume beep, increase oxygen delivery by adequate cardiac filling, adequate hemoglobin, decrease oxygen consumption by mechanical ventilation, sedation, avoid fever, avoid further injury by protective lung strategy, conservative fluid measure, and bronze position. Thanks.
قلنا الاثنين ولا واحد؟
لا هذا بجيبه.
هذا ما يكفي؟
هذا له للنايم.
يعني السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. نشكر اللجنة المنظمة. الحمد لله بعد انقطاع سنين رجعنا لهذه الاكتيفيتي الحمد لله. Mr. Chairman, audience, السلام عليكم ورحمة الله وبركاته. This lecture is not for orthopedic surgeon. This is for the primary health care, for ER doctors, for the ambulance, for anybody attending the trauma. In orthopedic, although it is a very major cause leading patient to ER, in some hospital, 85% of patients walking to ER is because of some musculoskeletal injury. Domestic falls, RTA, fall down like this sport, but it is rarely causing any morbidity or mortality. But it indicates significant force. A fracture means that there is a great force impacted on the body. Always take care if there is a fracture above diaphragm, and there is another fracture below the diaphragm. Clinical feature is simple. When you see a patient lying down with some abnormal anatomical position, we know the anatomical position, so there is abnormal anatomical position. The hand, the leg like this. There will be pain. There is tenderness at that area, although don't try to get it. There is always a swelling because of a hematoma, and the loss of function because of the arm, the lever arm. There is some attitude, also you don't need to know about it, and the crepitus, which also sometimes the first presentation is numbness or pulseless. Dislocation is disruption of the joint, like the knee, the hip joint, the shoulder joint, and the same clinical manifestation and the attitude or the position, it is abnormal in position. Many causes, the leading cause in the last recent studies is domestic, although we think it is RTA, but domestic injuries, it's in the house, fall down in the bathroom or during playing in the house. But there are many causes for musculoskeletal injuries, sports, RTAs, and other things. In fracture, we like to take this simple classification, close or open, because this will make a big difference in the outcome. Other classification, you don't need to know it. Closed means there is no direct exposure of the hematoma of the fracture to the exterior, although near or far. Open, when there is an open wound and the hematoma of the fracture is exposed to the exterior. And grade 1, grade 2, grade 3. Grade 1, simple puncture wound. Grade 2 is an open wound more than 5 to 10 centimeters, but still you can close it. Grade 3, the extreme is with a vascular injury and nerve injury. Complication, put in your mind that it is also, although rarely cause mortality, but there are grave some complication. Hemorrhage, we know all about hypovolemic shock in fracture femur, bilateral fracture femur, fracture pelvis. So we have to keep in mind. There is late complication and early complication. Just keep them in mind during your early first aid. Regional and systemic. In regional complication, gas gangrene, compartment syndrome, and vascular injury or nerve injury. Osteomyelitis, this is also late. Management. This is the whole topic of is how to treat the fracture or musculoskeletal injury in emergency. We don't need to discuss about definitive management because this is for orthopedic people. In emergency, the first one who comes to the injured person is not a doctor. So this lecture is for them, how to treat or manage a musculoskeletal injury patient without causing him further harm. So it is at the scene, in the ambulance, in ER, and then transfer. Pre-hospital personnel in ambulance or in fire workers or policemen. Always keep in your mind our ABC, not Dr. Qasim ABCs, because I don't know from where I got that ABC. This is our ABC, airway. Now we are talking about fracture, but still you have to go through your ABC, airway, breathing, oxygenation, circulation, control of hemorrhage, disability, neurological status. You have to confirm and document any disability, and then expose and environmental control. Examination, always start with looking. Don't rush to examine. Look. If there is a deformity, that's enough. You don't have to put the patient in pain by moving it.
feel distal circulation and feel the sensation, this feel. Still, we didn't do mobilization. Move, last thing. First active. First, you ask the patient to move. If the patient can move, then you can move it. Patient cannot move it, don't move it. It is painful and it may cause harm. Check the pulse, motor, sensory, not tense. Keep in mind compartment syndrome. Then start your IV fluids as ATLS protocol, ABC, oxygenation, alignment. This is in the primary survey. Primary survey, don't treat fracture, treat the airway, breathing, circulation. But during the primary survey, just do alignment and splint. This is the two things I want you to get out from this lecture by alignment and splint. That's it. Joints, difficult sometimes to diagnose dislocation. This is alignment. See, just put it in anatomical position. It was angulated, just align it. You will improve pain, will improve circulation, will improve mood of the patient. Why to splint and splint them where they lie? Whenever you find a patient with a fracture, splint, don't mobilize, don't transfer till you splint the patient. After splinting and alignment, do the ATLS, pulse, motor, sensory. Why? This is the question now we want to keep in mind. Splinting will reduce the hemorrhage by tamponade, by increasing the soft tissue tamponade. So it will relieve pain and it will lower the embolism. Further soft tissue injury. Once you control the distal part, there will be no any micro movements. So it will reduce further injury for the arteries or the nerves. Then how to splint? I don't have a splint. Always there is a splint. Walking sticks, umbrella, wood, anything. So زي جدودنا حطوا خشبة من هنا وخشبة من هنا واربطوه. Anything. You didn't find anything, upper limb to the body, the leg with the leg. Splint him by any mean. Always try. Now this conventional splints, it is available in all ambulance, even with the fire workers, they have it. Like these things. See, just a point of importance. Thomas splint, we know this Thomas splint. In World War I, mortality rate of femur was 80%. Femur fracture, mortality rate was 80%. Till they introduced Thomas splint, it reduced the mortality to 20%. So it is a big difference. So splinting means something. Put it in your mind. After you splint, you want to transfer the patient, check your pulse, motor, sensory, and then transfer the patient to the ER in ambulance, maintain your IV fluid, oxygen, maintain immobilization, never remove immobilization. And monitor the patient, muscle, pulse, motor, sensory, and check it is not tense. In ER, once the patient came to ER, consider yourself the first one who see the patient. Don't consider that, oh, he has a splint, that's okay. Okay, he doesn't have a splint, that's okay. Go through the patient as you are the first one who see the patient. Do your ABS, ATLS protocol, start IV fluid, oxygen, maintain normalization, monitor, pulse, motor, sensory, not tense. Now you will go through details, history, mechanism of injury, that he was ejected, another death in the scene, there was any gases, there was any contamination, environment, patient was drunk, was okay, he has medical history, and then you go for the examination, which always first you look, feel, circulation, and do X-ray. Always in X-ray, try to get good views. Don't accept bad views. Don't accept non-clinical views. There is a joint above, there is a joint below, and it will be, should be AB or lateral or OB, AB and oblique according to the part of the body. Open fracture. Sometimes it is terrifying. I put this simple one just not to extract you from the lecture mode. Sometimes it is very terrifying. The femur is outside and very bad with slough and open wounds. Still, treat the patient in ATLS protocol. Even that terrifying fracture doesn't mean anything because it will not lead the patient to death now. What will lead the patient to death is ATLS. What is the difference in open wounds? If there is active bleeding, this is in primary survey, just you back it. Don't probe it. Don't explore it. Wherever is the patient, unless it is in OR. Don't open the wound. Don't try to see what is going on. No, just wash it, back it, splint it. The management is the same. Now only this is the difference: compress it, back it, wash it, cover it, splint it, tetanus according to the hospital policy in some part of the world, and antibiotic if indicated. Check the pulse, the motors, the sensory, and then transfer the patient. So there is no difference between open or closed, but just to back it. Do not open it, do not probe it, do not try to examine is the tendon is intact or the pulse is intact. Feel the circulation, feel the movement. It's better than to probe or to explore the wound in the scene or in ER. The only place where you need to see the wound is in OR. Cover it. Don't push some bones which protruding outside. Don't push it inside because you will carry contamination. Just cover it. Cover it with anything. Covering with a handkerchief, with a bed sheet, shmagak, أي شيء. Just cover it with a clean fabrics and splint it. These are some examples of major and potentially life-threatening, like major pelvic disruption, major arterial hemorrhage, like in proximal femur fracture, crush syndrome with rhabdomyolysis and renal failure, limb-threatening injuries like open fracture, maybe blade presentation, vascular injury, compartment syndrome. Keep it in mind. It is very common, more than you think. Nerve injury, sometimes we think because of the pain, patient doesn't feel. Because of the pain, patient cannot move. Keep it in mind. Orthopedic consultation for definitive treatment. What I want you to get from this is always go through your ATLS protocol. Don't look for the fracture. Even if the femur is protruding outside the skin, do your ATLS, do ABC, look, feel, move. Active movement, ask the patient, this is active, ask the patient to move. Then passive movement. If the patient can move, you move it. Patient cannot move it, don't move it. Do alignment with the patient in anatomical position. We know anatomical position. It's an all anatomy. And look, feel, move, transfer, and always keep complication in mind. Thank you very much.
شكرا.
بس معلقة عليها.
افضل. ما شاء الله. رطب. السلام عليكم ورحمة الله وبركاته. كل عام وانتم بخير. صراحة I'm very happy إنه after 34 years this conference is still going on. The first time this conference happened in عام 1408. Very 1 minute story. كانت كل بعثات الحج تجي ومعها بعثات طبية. فطبعا كانوا يعني بعضهم يستغلوا البعثة الطبية للسكن، بعضهم يستغلوا البعثة الطبية لل وات ايفر. ما كان المهم انه كان بعض البعثات في لها مستشفيات في مكة وهم ماشيين كانوا يوزعوا الأدوية، والأدوية دي انكلود بيثيدين، مورفين، يو نيم ات. فجاءت أوامر من مع الوزير الله يرحمه الاستاذ فيصل حجلان انه حلوا لي المشكله دي، انا شايف بتدين في الشوارع، يعني هو السيكونس حقها. فسوينا لجنه البعثات الطبيه الاجنبيه، تشرفت اني انا اراسها. فبداوا يتململوا البعثات انه انتم جالسين كنترولينج، مثلا احنا من بلد A مرضانا يحبوا الادويه هذه او هذه ادويتنا. طب بيجيبوا كانوا ادويه نت ريليتد للحج. فمن هنا طلعت فكره مؤتمر الامراض الشائعه في الحج. واول مؤتمر صار في 1408 شرفت اني انا رئيسه، وكان رئيس اللجنه العلميه الله يذكره بالخير الدكتور بكر كارم. يعني هذه نبذه قصيره بس. ها؟ لا ما Okay. What does the burn mean? Burn means that it's the cell death by thermal injury and protein denaturing, changing the nature of the protein. Goes to cell death. When we have a burn patient, we have to do the assessment. Assessment include type of burn depth, size, and we have to look for the existing medical disorder and associated injury. Etiology, it's or type of what is causing burn is scald burn by oil and water, flame burn, flammable liquids, flash burn, explosion gas, contact burn, hot metals, electrical burn, and chemical burns, acid and alkali. Okay, for burn assessment, this is a picture of skin, piece of skin. We have dermis, epidermis, and subcutaneous tissue, and very interesting. You can see the nerve ending there, which is give us the depths of the burn. And when we get this, we know the depth of the burn is related or correlated with the pain itself. So with a very painful burn, it's a very superficial burn, and then feeling burn, or you don't feel anything of pain, that's mean this burn is very deep.
كده الله سبحانه وتعالى يقول كلما نضجت جلودهم بدلناهم جلودا غيرها ليذوقوا العذاب. يذوقوا العذاب معناته تتبدل الديرمس والإبيديرمس عشان يوصل يعني recreate the nerve ending so they can feel the burn. هذه من إحدى معجزات القرآن يعني. Okay, classification of burn, as I said, the depths, we have superficial thickness, we have second degree, it's partial thickness, and superficial and deep, and then we have a full thickness. The full thickness include all the dermis, epidermis, subcutaneous tissue, and the fourth, sometimes they call it because it reaches up to the tendons or bone or muscles. Okay, pathology of burn. When the burn happens, we have three zones. The zone of coagulation, which is the center of the burn, and it's surrounded by a zone of stasis, and then zone of hyperemia. When we do a good resuscitation, the zone is, or if the patient didn't resuscitate or they have a good resuscitation, that's lead to either the burn itself, it increase in size or in the percentage area or decrease, because good perfusion it change the zone of stasis to zone of hyperemia, and then the area improve. Otherwise, if the patient dehydrated, isn't resuscitated well, all these zones go to zone of coagulation and then get a full thickness burn. Okay, superficial thickness burn. This involves superficial epidermis, very painful, dry. There is no scar, no blister. Heal within 4 days. This is actually seen now in the Hajj because of the hot weather. During the whole, most of the year, we see it when they do skin tan. Under direct sun without the protection, you can see the first degree or superficial burn. Partial thickness burn, superficial, it's involved only the upper part of the dermis. It's red, wet, painful. There is a blister, and it forms scars, but it heals within 2 weeks. So the scar is not really permanent. There is a area of scar, but it's not like like this one. This baby has a facial burn. This is second degree. Okay, it will heal, but with a scar for at least two weeks, and then it mold by time. Partial thickness burn, deep, involve particular layer of dermis. It's formed blister. It's a dry. It's not painful at all. Heal in 3 to 9 weeks with hypertrophic scar. So this is where we need surgery. Okay, full thickness burn. This includes all the layers of the skin, and it's pale, rubbery, black. Can see fat or texture underneath it. It's insensate at all. It's no blanching because there is no capillary, and heal with scar formation. And this is definitely need excision and graft. So, and this is 4th degree when it reaches the bone and deep tissue. Okay, this is the burn depth, and this is just a comparison. Which one is superficial dermal, deep, full thickness, and all we have this category. Burn size is rule of 9. We have this rule of 9. We have Land browser, and we have Palmer method. Anyone can use it. Your palm is about 1%, and then we have the rule of 9 all over the body. The arm is 4.5 and 4.5. The arms, the leg is 9 because it's bigger, and the chest, abdomen, and the whole trunk is 18. So this is all scheduled. All papers, they are found in the emergency room in any hospital that you can calculate and draw what area of burn and what degree the patient have. Okay, prognosis for patient is older patient, more than 50 years, it get worse, associated injury, associated illness, and for the burn itself, the depth of burn and total body surface area and inhalation injury. So what do you do when you have a burn patient? Acute burn management, ATLS, as everybody said, airway, C-spine, breathing, circulation, disability, exposures to the burn, still patient exposing to the burn, and adjuvant treatment, airways and C-spine, assess whether the airway is compromised or at risk of compromise. Inhalation injury above the vocal cord, edema over time, especially after fluid resuscitation. Sometimes you just find redness around above the vocal cord because the patient is dry. But when you start to give fluid, the first thing is patient gets stridor and they suffocate. And of course, cervical spine should be protected. Indication for intubation, erythema or swelling of oropharynx on direct visualization, change in the voice, hoarseness, stridor, dyspnea. So low Glasgow Coma scale. This is indication of even sometimes you have to intubate at the scene of the accident. So the management airway is intubation, early, nothing else. Breathing, mechanical ventilator, and if you have the burn on the chest, the patient may have like a complete restriction of the movement. Sometimes you have compartment syndrome of the chest wall. The patient cannot expand his breath. So, especially this come in blast injury, in any injury you cannot see any a real or actual burn on the chest skin. You look there, okay, the chest is a little bit red or something like that because of the blast injury, or he was a patient comatose near a very high heat object, and then you may get this problem. And of course, we have a problem with inhalation injury, mechanical restriction of breathing, limited chest movement. So patient need partial thickness burn, circumferential burn of the chest wall. So in this thing, we have to do sclerotomy or even fasciotomy of the chest wall. So sign, we have a deep circumferential chest burn, rapid shallow breathing, increased PCO2 level. So this is a picture of like complete full thickness burn of the chest. You just go straight, even sclerotomy. You don't need anesthesia. You just go sterile the area with anything in the emergency room, and you just get your scalpel. If you are in OR, you can use cautery, but you can go anteriorly on the axillary line, anterior auxiliary line. Sometimes you have to connect the two lines so the chest can move together. This is a picture of sclerotomy on one of our patients here. So penetrating injury, tension pneumothorax from the blast injury and lung contusion, airway trauma leading to ARDS. Injury to the pulmonary parenchyma, confirmed with inhalation injury, increased mortality by 40% when we have inhalation injury. We have inhalation, we have three aspects. CO2 is undertaker because the CO2 have affinity to link to the hemoglobin 200 times than oxygen. So we have a result in the left shift of the oxygen curve association, and when we do oxygen saturation, this is not a true reading, And we have carbon monoxide toxicity like hallucination, confusion, nausea, vomiting, shock, and maybe sometimes go to death. Thermal injury to upper aerodigestive tract can be delayed until full resuscitation started. Chemical injury will cause bronchospasm. This is all under inhalation injury, and so it can cause bronchospasm, bronchorrhea, that results in edema and will interfere with the gas exchange. So signs of inhalation burn: enclosed space, loss of consciousness, carbonaceous sputum, tinged nasal hair, stridor, hoarseness, facial and neck burn, and all inhalation is confirmed by bronchoscopy. So this is what we do, and this is our confirmation. You can do lavage, you can do all things by bronchoscopy, and ask our colleagues in ICU to do bronchoscopy and clean up and have a direct vision for that. Treatment of inhalation injury: early detection, intubation, and give 100% oxygen. Inadequate fluid resuscitation, hypovolemic shock, acute renal failure when you have improper resuscitation to maintain circulation. And when you do aggressive resuscitation, you have edema and tissue hypoxia. So aim of maintaining our circulation is urine output as a rough standard, 1 ml per kilogram per hour in children and 0.5 ml per kilogram per hour in adults. Many formula exists using different solution, mainly used as a guide. So we have to insert 2 large bore peripheral IV lines and put a Foley catheter to calculate input and output. And the greatest amount of fluid loss in the burn patient is in the first 24 hours. So the ambulance transfer the patient to the hospital, and then you can start at the scene, or if the patient transferred from the other hospital, you should ask about when the burns happen and what fluid is given and how much. Because you have to calculate by Bartland formula total amount. Either you give him more when he arrived to your hospital, or decrease the amount so to give him optimal fluids. So Bartland formula is 4 milli per kilogram per total body surface area of ringer lactate. 50% given in the first 8 hours, and 50% given in the next 16 hours. In children, Bartland plus the maintenance is 4 ml per kilogram for the first 10 kilograms of the baby, plus 2 ml per kilogram per hour for second 10 kilograms of the body weight of the baby, plus 1 ml for the more than 20 kilo of body weight. Inhalation injury required increase the amount of fluid by 50%. Electrical injury is we can go up to 9 ml per kilogram per total body surface area in the first 24 hours. And we need higher urine output, because we know electrical injury, it mainly goes through the muscle and end up by rhabdomyolysis, and it may cause renal failure. So we need really higher urine output. Circumferential extremity scar lead to vascular compromise of extremity. Signs of vascular compromise: cyanosis, deep tissue pain, progressive paresthesia, progressive decrease of or absence of pulse, and cold extremity. So this is the way of releasing that. This is part of the compartments. You go lateral, you avoid lateral coronary nerve here. You go either anterior, You go away from the fibular head, and you try to do your sclerotomy or even go fasciotomy. When you go fasciotomy in the posterior to release the compartment, you have to also consider the soleus muscle, not to be forgotten, and you release your pressure. So fasciotomy required if evidence of compartment syndrome or intercompartment pressure is more than 30 millimeter mercury. So this is lines of sclerotomy. Again, this is sclerotomy in fasciotomy of the hand. You go to all the boral aspect, and of course you have to go for release carpal tunnel. So you have complete release all the carpal tunnel and goes as proximal as you have to. Okay, pain control is morphine, IV, 2 to 5 milligram, till the pain controlled. Gastric decompression by nasogastric tube. A patient prone to develop ileus. So early internal feeding prevent stress ulcer, prevent bacterial translocation. So it helps really in the management, psychological care because of the burn itself, and we give a realistic assessment with the prognosis to the patient and the family. We give also tetanus toxoid according to the hospital protocol. For antibiotic, systemic antibiotic is reserved for cellulitis. We never give IV antibiotic as a prophylactic because 95% of the burned skin, they are sterile in the first 24 hours, so we don't have to give. And then we just go for topical antibiotic. We have sulfadiazide, sulfur nitrate, bifenide acetate. So this is the burn wound care agent. We have sulfadiazide, it's poor for scar, poor for scar, sulfur nitrate poor. The only thing is excellent for scar penetration, and we love to use it in the ear when the ear is or the nose burn to penetrate scar and protect our cartilage. Is sulfamylone. Okay, and we have also the Acticot. We ought to have it here in our hospital. Its penetration is intermediate and decreased dressing change, but it's painful and sometimes it's dress your wound with the black color. Okay, avoid catabolism, adequately nutrition, nasogastric tube, or you cannot because of any reason, you try CPN and supplement of vitamins and mineral. Criteria for burn admission to the burn unit. There is 10 categories you should be admitted to the burn unit according to the American Burn Association. In the children, 2 to 3, second to third degree, more than 10% total body surface area in the extreme age. Again, a burn more than 20% in young people. 2 to third degree burn involving the face, hand, feet, and genitalia, perineum and major joints, electrical burn, chemical burn, inhalation injury, pre-existing medical problems, combined mechanical thermal injury, in which the burn wound process grades. We have also the electrical burn. It's very important to admit him, even if you don't have a burn unit. You can admit him in ICU because you need to do cardiac monitoring. So burn wound care, we can do early serial excision, standard practice for deep burn, full thickness burn exercise first, and then the deep partial burn, and then grafted. Intermediate depth burn observed 7 to 10 days. Superficial partial thickness can be treated with antibiotic dressing. Topical antibiotic, marked reduction in infection, no prophylactic systemic antibiotics. Start with the infection control, prevent burn wound sepsis. Interrupted skin will lead to infection and loss of fluid and pain. So we have to do wound infection care and then prevention by topical antimicrobial and early excision and grafting of the deep burn area. So in the burn surgery, either we do sclerotomy, fasciotomy, excision, and skin graft. Goal is to preserve life, prevention and control infection, conservation of viable tissue, maintain function, timely closure of the burn wound. Early tangential excision and grafting. This is like done in 1970s. Deep partial and third degree burn only when immediately closed and wound infection. Excision of fascia, less blood loss, fast excision, but it has a very bad cosmetic results. This is our Hamby knife. And this is when we use it. And type of graft, to have autograft for thickness, cultured skin. We have allograft, cadaveric skin for temporary wound coverage. Xenograft is from the other species, and we don't use it here. Okay, this is a dermatome, electrical dermatome, and we can take really a nice split thickness skin graft, and we don't lose or take any deep like the Hamby knife. And sometimes you are forced to do Hamby knife. It's not available. This is a wound of a split thickness, harvesting split thickness skin graft. This is after we mesh it. This is meshed 1 to 3. So we can gain more surface area. And again, this is a picture of the depths of the, sorry. Yeah, the depths of the split thickness skin graft. You can take it up to this level. The most important area is just leave the base of sebaceous and residual cell for regeneration of the skin. And this is when we do excision and skin grafting. Another case. Okay, excision and skin grafting. This is after the grafted skin healed. Of course, we have some ishkar around. It will go when we do shower and moisturizing the patient wounds. It will give a good result. And this is another skin graft in the sclerotomy area. Okay, rehabilitation, psychological well-being, start as early as possible as skin graft is taken to prevent contracture, because the contracture really is very difficult, and it's okay, it's not well looking to the patient and his family or his surrounding, and also sometimes if we leave it long, really, because all the internal structure start to be shortening. So after the skin graft is stabilized, 3 to 6 weeks maximum, we should go and correct all the deformity. Okay, electrical burn. Classification is voltage, low or high voltage, current, alternating current, AC, or it's more harm than the direct current, DC. Mechanism, flash, arc, contact, burn. Prognosis, type of current, AC or DC, pathway of current, voltage, resistance of the body, duration of the contact. All these factors affecting the prognosis. Deep muscle necrosis, rhabdomyolysis, myoglobin, and then release give us acute renal failure. Cardiac give us arrhythmia, contusion, MI, and sometimes myocardial aneurysm, left ventricular aneurysm, also has CNS or peripheral nerves, cataract, lung bone fracture because of the power of the muscle contraction and have sometimes the bowel perforation. So again, ATLS protocol, abdomyolysis leading to acute renal failure. We have to keep an eye on this, watching the urine creatinine. We have to give a lot of fluid, alkalize the urine, and if you have a compartment syndrome, you have to release it, and the patient should be 24 hours monitor in monitor bed. Chemical burn, we have the reduction agent, we have oxidation agent, we have corrosive agent. Corrosive is mainly or sometimes or most common in house problems. We have phenol, which usually form shallow ulcer and scar. Oxidation agent, the sodium hypochlorite, the bleaching agent اللي برضه يستخدم في تنظيف الفلورز okay. So always try to avoid, take the patient away from the source of the danger, ATLS and all this, germ management, remove clothing, wash him, and it depends on the agent itself. And you have hydrotherapy, you have calcium gluconate. It depends on the anything. Thank you. Sure.
Assalamu alaikum everyone. My name is Samah Kalanta, consultant neuroimaging. First of all, I would like to thank the organizers for having me today in this major conference, in a major event. And second of all, I'd like to thank all of you for coming. And I wish you Eid al-Adha Mubarak, and may Allah accept your good deeds, supplications, sacrifices, and those who will make Hajj, may Allah accept from them also. Today's topic is of particular interest for those of you who works in emergency, radiological, and medical departments. So it's about common non-traumatic intracranial emergencies. So during the next 30 minutes, we will talk about cerebral ischemia and infarction, venous signs, thrombosis, intracranial hemorrhage, basically the causes, how to approach hydrocephalus, and then cerebral herniations. So what is cerebral ischemia? It is a common mechanism of acute brain injury that results from impaired blood flow to the brain. It is the most common cause of morbidity worldwide after MI, and is a leading cause of acquired disability. The risk factors mirror the risk factors of atherosclerosis, which include age, gender, family history, smoking, hypertension, hypercholesterolemia, and diabetes mellitus. So first, what is penumbra? Following any arterial occlusion, a core of brain tissue dies rapidly. And surrounding this core, the one in blue color, there is an area at risk, but they're still salvageable. And if with the time passage and if the occlusion remains, the infarct core will grow and progressively replaces the ischemic penumbra. And if prompt recanalization happens or achieved by any means, so this ischemic penumbra can be salvageable or rescued from infarction. So that's why time factor is important and crucial in the diagnostic and management plan of ischemia. So what are the types or variants of ischemia? We have territorial, that is either involving the anterior or posterior circulations. We have lacunar infarctions, which are infarctions less than 5 millimeter. We have global or hypoxic ischemic encephalopathy and watershed or border zone infarction. So what is the aim of imaging? First, to exclude intracranial hemorrhage and other mimics of ischemic stroke, such as, for example, infection, neoplastic, and other entities. Provide reliable information about the location and extent of ischemia. Identify the existence and extent of potentially salvageable brain, which is the ischemic penumbra. And also identify the site of vascular occlusion and degree of collateral flow. Starting with CT, that is the protocol. Of course, non-enhanced CT is the initial modality of choice, which is widely available and cost-effective. And then we have the perfusion CT and CT angiogram. For the CT angiogram, basically we have CT arteriogram. The aim is to visualize the artery, so that's why it is an arteriogram. So what are the findings on non-enhanced CT? Any vessel that is acutely thrombosed, it will appear dense. So we have, if it's affecting the middle cerebral artery, we have dense MCS sign. The parenchymal changes include loss of gray-white matter differentiation, parenchymal hypoattenuation, and loss of local mass effect. So if it's affecting the insular loop, we call it insular ribbon sign. And if it's affecting the basal ganglia, we call it vanishing basal ganglia sign. One thing to mention about CT, whenever the radiologist is viewing any CT brain for acute stroke, we have to adjust the window to make the resolution between the gray and white matter a little bit more higher. So this is the first picture on the left side is the usual brain window. So this is the stroke window, and it shows the loss of gray-white matter differentiation in the right frontal lobe. So image A demonstrates the dense MCA sign, and B demonstrates the insular ribbon sign, which is loss of gray-white matter differentiation of the right insula. أنا أعرف كيف البوينتر؟ صبيح كيف ما نعرف؟ هذه. So this is the dense MCA sign, this is the insular ribbon sign. MRI protocol, usually we do the routine protocol plus the MR arteriogram, and also the MR perfusion. Usually, no need to give contrast for ischemic cases. For the routine MRI sequences, we basically focus on diffusion weighted images, T2 and FLAIR images, T2 star, or other name we call it GRE images, which is sensitive for hemorrhagic products. As we said, MR perfusion and MR angiogram. Basically, the MR angiogram, no need to give contrast. So whenever there is a normal high flow within an artery, it will appear as an enhancing structures. So what are the findings? Basically, we have diffusion restriction, which appears hyperintense on DWI and hypointense on ADC map. We'll see later a few examples. The infarcted tissue or the ischemic tissue will appear hyperintense on T2 or FLAIR images. T2 star, sensitive for hemorrhage. Perfusion basically demonstrates hypoperfusion or deficits. And MRA will demonstrate lack of flow. Okay, in this image, as you can see, this is the DWI images, which demonstrate hyperintensity of the left insula. So basically, you have to correlate it with the ADC map. If it's low on ADC map, so that means it is an acute ischemia. The MR perfusion demonstrates the one in red line demonstrates the perfusion deficits or the perfusion, which is called the ischemic penumbra. This is like a back to front view of 3D MRA images, which demonstrate this is the right MCA normally, and this is the left MCA, which demonstrate lack of flow. And this is the T2 star images, which demonstrate hypointensity within the left. It's a little bit higher level. So it demonstrates like a low signal in the left basal ganglia, which is sensitive or which represents the hemorrhagic component. So main advantages of MRI over CT. It is more sensitive for the depiction of acute ischemia in hyperacute stage. Also, the ability to stage the ischemia, acute from chronic. Sometimes we cannot differentiate it on CT. Visualize small lesions not evident on CT scan, particularly in the posterior fossa, and also for lacunar infarctions. And also, it helps us to understand the mechanism of stroke by analyzing the location and pattern of ischemia. So in this case, this is non-enhanced CT, usual brain window. We don't see anything evident. But on DWI, we see like a hyperintensity at the posterior limb of the right internal capsule, which is acute lacunar infarction. So now moving to the variants of ischemia, this is the global or hypoxic ischemic encephalopathy. Basically, it's related to an acute event or respiratory cardiac arrest, near drowning and asphyxia. So basically, the anterior circulation are affected more. So as you can see here, there is loss. This is the supratentorial brain, which demonstrates loss of gray-white matter differentiation, hypoattenuation, loss of local mass effect. As you don't see the normal sulci, you don't see the ventricular system. And basically, the posterior, circulation for the posterior fossa is a little bit preserved. So we call it white cerebellar sign. So this is typical for global or hypoxic ischemic encephalopathy. In this case, about 10% of all ischemia, there is, we call it watershed or border zone infarction. So usually it happens between two major territories. In our image, we have acute diffusion. This is the DWI and this is the ADC map. So there is diffusion restriction basically at the bilateral temporo-occipital junctions. So the ischemia here between basically the PCA and MCA territories. The usual mechanism is either hypoperfusion or embolism. Moving to the next topic, which is venous sinus thrombosis. So what are the factors, risk factors? Basically, we have hormonal, such as OCPs, hematological conditions, such as polycythemia, local factors, infections like meningitis, head injury, any fractures that is closely related to the neural venous sinuses. Systemic illnesses such as dehydration, sepsis, malignancy, connective tissue disease, and in about 12% it is idiopathic. So the same concept in arterial ischemia, the thrombosed vein will appear dense, and the parenchymal changes usually vasogenic edema. It's not cytotoxic edema. So, and it's usually related to secondary venous hypertension and more to be hemorrhagic at the initial presentation, not unlike the ischemic ischemia, the arterial ischemia. On CT venogram, we have, of course, filling defect within the lumen of the vein. If it's affecting the superior sagittal sinus, we have typical sign, we call it empty distal sign. So as you see here, this is the non-enhanced CT, this is the CT venogram. The part of the straight sinus, and this is part of the superior sagittal sinus, appears dense and more bulky. Post contrast venogram demonstrate a filling defect within them. This is mid-sagittal view. Again, demonstrate the same finding. This is the filling defect within the superior sagittal sinus and the straight sinus. So there are some pitfalls, or we can call it differential diagnosis. There are some anatomical variations like arachnoid granulations, hypoplasia, or aplasia. For arachnoid granulation, it's like CSF-like structures within the dural sinuses, and it will appear as filling district. The usual location at the lateral aspect of the transverse sinuses. So it's basically, we know it by the attenuation or the signal intensity. It's usually CSF-like. Another pitfalls is there are some systemic conditions that cause diffuse increase in the blood vessel density, such as elevated hematocrit, polycythemia, and severe dehydration. So here, as you can see, all the vessels are hyperdense, but usually in such case, it was related to one of these conditions. Moving to the next topic, intracranial hemorrhage. Basically, the causes. Under vascular category, you have a lot of causes: hypertension, cerebral amyloid angiopathy, hemorrhagic conversion or ischemic infarction, ruptured aneurysms, AVM, dural AVF, vasculitis, venous signs thrombosis, sickle cell disease, and myeloid disease. We have coagulopathy, toxic metabolic processes, and possibly infectious and neoplastic processes. As everybody knows, the locations of hemorrhages either intraaxial, intraparenchymal, and extraaxial, epidural, subdural, and subarachnoid, as well as intraventricular. On CT scan, there is something called Hansford units. We can measure the material, the net. We can know the material of the objects of interest by measuring the Hansford unit. So basically, for acute infarction, for acute hemorrhage, the acute hemorrhage first, it will appear hyperdense on non-enhanced CT, and usually the Hansford unit between 65 to 95 Hansford units. And on MRI, it helps us to stage hematoma if present. And the most sensitive sequence are the T2 or GRE sequences, as you can see here on this image. There is a microhemorrhage at the left parietal white matter. So a few examples of intracranial hemorrhage. This is an acute infarction along the right insula and basal ganglia. So on follow-up scan, we have hemorrhagic transformation. This is non-enhanced CT angio, and this is the volume rendered reformats from the CT angio. First, it demonstrates a massive acute subarachnoid hemorrhage along the basilar system, surrounding the midbrain, and also intraventricular components. CT angio demonstrates a focal outpouch at the location of the ecum, which is demonstrated here as a circular aneurysmal outpouch. Okay, so in this case, it was ruptured aneurysm. Okay, in this case, this is non-enhanced CT scan. This is CT angio, and this is the digital subtraction angiography, lateral view. First of all, it demonstrates a large intraaxial hematoma, acute hematoma, at the right frontal lobe with mass effect. And then on post-contrast images, it demonstrates, say, a group of abnormal blood vessels anterior to the hematoma. And the DSA images demonstrate a group of abnormal vessels, this white arrow, abnormal blood vessels, and the arrowheads points to an early draining vein. These signs are, or findings are typical for arteriovenous malformation. Okay, non-enhanced CT, these are all MRI images, T2 weighted images, GRE images, and post-contrast images. So as you can see, there is a high left parietal intraaxial acute hemorrhage. And again, it demonstrates the same finding with more depiction of the right frontal changes, parenchymal changes. And here demonstrate the hemorrhagic component. And the post-contrast images demonstrate filling defects within the superior sagittal sinus, as well as the cortical vein. So in this case, it was venous sinus thrombosis with hemorrhagic parenchymal changes. So these are suggested guidelines for imaging patients with non-traumatic intracranial hemorrhage. So as we said before, non-enhanced CT are usually the procedure of choice for initial evaluation. And CT angio is generally performed for all patients. without clear cause of the intracranial hemorrhage. And it is not required for older hypertensive patients and who have hemorrhage in the basal ganglia, thalamus, cerebellum, or brainstem. MRI is considered for patients with suspected neoplasms, amyloid angiopathy, vascular malformation. And this is considered for those patients who require angiographic evaluation and are potential for vascular interventional candidates. Moving to the next topic is hydrocephalus, which is an expansion of the ventricular system on the basis of an increase in the volume of the CSF contained within them. So in order to understand the mechanism of hydrocephalus, basically we have to know the CSF flow dynamics. So basically the CSF is produced at the choroid plexus, usually at the larger ventricles, the one in the red, and also the fourth ventricle. So CSF production is happening here, and then it moves to the third ventricle. This is the fourth ventricle, and then it moves or enters the subarachnoid spaces of the spine and also the cerebrum, and then goes to the arachnoid granulation and gets reabsorbed to the systemic circulation through the venous sinuses. So any interaction at any point will cause hydrocephalus. So these are basically the mechanism. Usually in early acute hydrocephalus, the temporal ventricular horn are more sensitive. So whenever we are imaging or we are looking for acute hydrocephalus, we focus on the temporal ventricular horns. This is an example of a normal brain. This is brain atrophy, which we call or describe it as proportional dilatation in the ventricular system and the subarachnoid spaces. Unlike the hydrocephalus, which is disproportional dilatation of the ventricular system relative to the subarachnoid spaces. Basically, the classification, we have either non-communicating or communicating. Non-communicating, we're seeing something that is obstructing or disturbing the flow, the CSF flow, either intraventricular or extraventricular. Intraventricular, we have either neoplasms, cysts, infection, webs, membranes, or aqueductal stenosis, and also any extrinsic compression upon the ventricles or connective channels. For example, there is a large basal ganglia acute hemorrhage, and it will cause compressive system and thus obstructing hydrocephalus. For the extraventricular, that is at the level of the arachnoid granulation, anything replaces the normal CSF within the subarachnoid spaces, either hemorrhage, infection, communicable cancer, cancerous cells. For communicating, we don't see any obvious abnormality that is obstructing the flow. Basically, at the level of the choroid plexus and another entity which we call normal pressure hydrocephalus. So these are few examples. Basically, 3 examples. Non-enhanced CT demonstrates supratentorial hydrocephalus. As you can see, there is widening of the temporal ventricular horn. There is cystic-like structure within the fourth ventricle. This is post-contrast sagittal T1 weighted image, which demonstrates peripherally enhancing cystic mass within the fourth ventricle. So basically, we have non-communicating hydrocephalus, and this cyst turns out to be neurocystic cirrhosis. This is another cause. We have basically the subarachnoid hemorrhage is the cause in this case of acute hydrocephalus. So subarachnoid hemorrhage causes either acute or chronic hydrocephalus. And usually it marks hydrocephalus occurs if the subarachnoid hemorrhage affecting the basal ganglia and posterior fossa more. In this case, as you can see, these are all post-contrast T1 weighted images, MRI, which demonstrate an enhancing mass within the lateral and fourth ventricle. So basically, it is non-communicating and obstructive hydrocephalus. This mass turns to be choroid plexus cancer. So in this case, the mechanism are related to overproduction and the obstructive effect. Last topic is cerebral herniations. Basically, it is a shift of cerebral tissue from its normal location into adjacent space. It's a life-threatening conditions and require prompt diagnosis. What are the hazards of herniation? Basically, brain damage. It compresses the adjacent cranial nerves, vessels, and causes hemorrhage, ischemia. And also, it can cause hydrocephalus. So basically, these are the types of herniation. We have extracranial and intracranial. Subfalcine herniation, whenever we have the cingulate gyrus of the frontal lobe moves to the other side under the falx cerebri. And we have transtentorial herniation. This is the tentorial reflection. So we have either descending or ascending transtentorial herniation, and this is a case of tensioner herniation. We will basically show you the images. So this is an coronal T1 weighted images demonstrate a large epidural hematoma on the left side, and it causes midline shift. And as you can see, the cingulate gyrus here is shifted to the other side. And the arteries are the anterior cerebral arteries. So whenever we are seeing any herniation, we have to look for ischemia. This is a case of right descending transtentorial herniation. This part of the medial temporal lobe, we call it the incus. So there is a medial deviation. And as you can see here, it affects the third cranial nerve and causes third cranial nerve palsy. And also the PCAs are at risk of ischemia. Okay. Last case we have, this is the foramen magnum. Okay. The part of the cerebrum, we call it the cerebellar tonsils, are herniating below the foramen magnum. So this type we have tonsillar herniation with hydrocephalus. This is an axial view. And this in tonsillar herniation, the vessels at risk, the one in white arrow, which are the, in white arrow, these are the vertebral arteries, and in the black, this is the anterior spinal arteries. So these are my references. Thank you for your attention.
Okay, together your there are many one of the enhancement this and other and brothers do they have so what do we have here in our hospital when this infectious disease hazard?
For that, we have already now policy for that, and we have drills monthly for that. And allow people in the area for receiving like cases. And till now, we don't have vaccine for this. And now we have some shortage, but the people is aware about that.
My next question is to what is the best indicator for outcome of traumatic pain? For somebody who's not neurosurgeon,
The best thing is the initial glaucoma state. The better the glaucoma state, the better the prognosis, the better the outcome.
We have an issue always with fluid therapy in the initial phase of resuscitation. Do you have any preference to somebody that has traumatic pain injury?
Usually we have to be cautious with the amount of fluid that we get. We don't stress about the ICU setting of giving fluid. Tomorrow we will have the ICU setting for traumatic brain injury management for Mariam, the neurointensivist. But initially, you should give the patients according to the ETNS protocol. And then once you do the CT scan, you can go with more fluid if there's no brain edema, but if there's brain edema, you have to restrict the fluid or give antibiotic. Good. Thank you very much. Dr. Qasmara? Anyone else has any questions? So I'm really happy to be part of this seminar about Hajj, and not just presenting my seniors and pioneers in Mecca, those are the pillars here, but also knowing that we have to advance therapy to the North Africa. So with this, and we ask Allah subhanahu wa ta'ala to follow our needs, inshallah, during this time, and inshallah, safe Hajj.
Assalamu alaikum. Our break, it will be for 30 minutes. Then at 11 sharp, we'll start the second session. Please be on time. Only we have almost 28 minutes. At 11 sharp, we will start the second session. في واحد ثاني طيب. هو ما يقدر يجلس. الثاني كلها طيب fix it تعالي ها؟ لا مو عيسى شوفي في بوينتر and بوينتر
يعني كلهم كلها ما هي راضية تشتغل. هلا ما
شغالة طيب خلاص أيوة السلام عليكم. Welcome again and we will start our second session and it will be moderated by Dr. Jamil Digna. Dr. Jamil is a consultant of internal medicine and he is also consultant of medical oncology and he is a head of medical oncology department at النور Specialist Hospital. Welcome, Dr. Jamil, and the floor is yours to moderate the second session.
It's a pleasure today to handle the second session of this seminar of the Hajj. It's my pleasure to introduce you next speaker, Professor Arzada. He's a membership of the International Medical College of Karachi. He had a fellowship in cardiophysiology in Pakistan. He's also a known speaker at the conference and researcher. If he has any publications, currently he's working as a urology specialist in an hospital, and he will talk about new treatment. Professor, you got to say.
هنا بطيء شوية.
Is it there? All right. All right. It can be used. Assalamu alaikum. Is it working? Yeah. Assalamu alaikum. Thank you so much for the introduction. And before starting my presentation, I would like to thank the management who has organized this beautiful Hajj symposium, and the Department of Cardiology, my senior colleagues. Acute heart failure is it's an entity that should be, known to every healthcare provider, not only the cardiologist, but the internist and the people in emergency departments, all the healthcare providers. So let's start with the background. Why heart failure is important? Because it's a major public health problem. If you see the prevalence of it's more than 5.8 million in the United States, and worldwide it's 23 million. And even in 1997, it was signaled out as an emerging epidemic. And today, I believe it's more than a COVID, heart failure. Why? You will understand in my next slides. Because despite progress in the reducing the heart failure mortality, a lot of research have been done these days in the last 5 years. I mean, for the management of heart failure, but still the incidence is rising. Still the mortality is high. So it's a today's epidemic, I believe, and the hospitalization for heart failure remain frequent, and rates of readmission is going to rise. So this slide is showing the expenditure, the economic burden. Like that was a study then that showed 69% of the hospital admissions with the heart failure, and if they are being sent for the device procedure, the cost also rises. The ICDs and CRTs. So this slide is showing how much effort people have done for the reduction of heart failure worldwide. I mean, in Canada, UK, and different part of the world. Why? Because it's the biggest threat to our healthcare systems, and we are approaching the tipping point. So the global epidemic. Another study that was published from the University of Ottawa, Canada, 50% of the patients diagnosed with heart failure die within 5 years. Can you imagine? 50%. It's a huge number. 40 million people are affected worldwide, around the world. 6 lakh people affected by the heart failure in Canada. 10 billion spent annually on hospital costs. #1 driver for unplanned hospital admission. And annual deaths from heart failure exceed the combined total breast, colon, and prostate cancer. So, that's important. So we need to reduce the burden of heart failure. How? I'll show you in a couple of slides later. So this is the pathophysiology of acute decompensated heart failure. It starts with the decrease when the heart fails, it leads to decreased cardiac output and blood pressures. And they increase the sympathetic activity, the RAS system, everything gets activated, increased vasopressin that leads to decreased renal flow ultimately, and increased central venous pressure, capillary wedge pressure is increased, and a vicious cycle starts. Okay, so this is a beautiful slide that is showing heart failure does not mean systolic heart failure only. Okay, so there's a new entity, diastolic heart failure. That's not new now, but people should know about the heart failure with the preserved EF. In this, they have got a problem in the relaxation. Okay, so this is also a lot of people come to the emergency department with a preserved EF. Okay, so we need to address both. Okay, so I'm not going into the detail of this slide, but I have put it this slide just to show you how many since 1986 till 2022 today. Lot of research have been done to decrease the mortality or to, I mean, for the management of heart failure, and they have promising results as well. I mean, being an electrophysiologist, during my fellowship, we used to receive patients that are referred for the device therapy for biventricular pacemaker. But as we start on the guideline directed medical therapy with these new magical, I would say them a magical or miracle drugs, they were deferred for the device therapy. Even then with the invent of these drugs, still the incidence of heart failure is high. Just to make you realize that, you know, we need to work on the preventive cardiology, okay? Rather than to, these drugs are there, but if you prevent the risk factors, we can hold the incidence of heart failure right at the beginning. If a patient develops a chronic heart failure, now it's very difficult, okay? So let's come to the acute heart failure, which is our today's topic, okay? So it's a life-threatening medical condition. I will focus on acute heart failure today. Urgent diagnostic and medical treatments are of key importance. And throughout the globe, the management is same. But some of the study that was done in East Asia that has shown that favorable results, the results in the first year are better than Europe. I mean, so there are regional differences in the, but overall the management is same. So this 3D real image of the heart, I have put it this just to make you realize, just imagine this heart pumps 5 liters of blood in one beat. Okay, in one beat it pumps 5 liters of blood to your body. And just imagine if it gets failed, if it's unable to do the pumping, what will happen? All the blood, you know, the congestion will occur and the patient goes into acute heart failure. And if someone has seen the patient who presents to the emergency department acute heart failure, he doesn't gives you time. I mean, if it's very important, okay? I mean, it doesn't gives you time to manage. So cornerstone of management would be identify the precipitating factors, whether it's ischemia, infection, other, I mean, renal dysfunction. A lot of precipitating factors can be there, which can be and specific type. Like, so we need a multidisciplinary approach in the management of acute heart failure. Congestion is the main symptom, both systemic as well as inside the organ. Like it involves the lungs, kidneys, and liver. And cardiac output is often preserved. The patient who presents with acute heart failure, cardiac output is fine, but it goes into failure because of the reasons. Why? So a lot of the research that have been done in European Society of Cardiology, American Heart, European Society Emergency Medicine, that have, so my presentation is, you know, based on all these research that have been published for the acute heart failure today. So still there is a lack of evidence. There are a lot of things which gives mortality benefit in chronic heart failure, but acute heart failure, there is lack of data. Physicians have to make decisions based on expert consensus document. Okay, you have to take the decision at the spot. So rapid recognition of symptom is very important. Identify the underlying cause, severity of heart failure, complications. You have to anticipate the complications which can occur through which the patient comes. Initially, specific treatment as soon as possible. Why? Similarly to acute coronary syndrome, acute heart failure patients might benefit time to therapy concept. That is important. Data have shown if you start the treatment of acute heart failure as soon as possible, so the mortality would be decreased. Okay, so that is important. So rapid diagnosis, regional differences should be kept in mind because in East Asia, there's a better survival than Europe. So what is the definition? Rapid onset, worsening of symptoms associated with elevated plasma levels of natriuretic peptide. That is very important. We'll discuss in detail this BNP because the brain natriuretic peptide is an important part to diagnose as well as for the prognosis. Requires immediate medical management. It can be first occurrence as a de novo, or it can occur as a chronic acute decompensation of
chronic heart failure. Okay, so 2 times, but more frequent is acute decompensation of chronic heart failure. So de novo mainly caused by primary cardiac dysfunction like acute coronary syndrome or ischemia, while the acute decompensation can be caused by infection, uncontrolled hypertension, rhythm disturbances, and non-compliance. That is very important with the prescribed drugs. So it's a multifaceted syndrome with various phenotypes. Acute pulmonary edema. Patient with acute heart failure can have a hypertensive crisis. Cardiogenic shock may be impaired or preserved. He can have a preserved as well as impaired ejection fraction. Right ventricular dysfunction alone. Acute heart failure can lead to systemic disorders and affect all the vital organs, and can lead to poor blood circulation, venous back pressure, and lower cardiac output. So classification, there are 2 different classifications. One is the clinical, which relies on the clinical presentation. Like patient can have a normal blood pressure or high blood pressure, 5 to 8% with hypertension, with a poor prognosis, especially if they are accompanied with hypoperfusion as well. So although relatively rare, cardiogenic shock is most severe form of acute heart failure with a bad prognosis. So I'm not going into the detail. I just wanted to show the definition of what is cardiogenic shock. Hypotension with a systolic blood pressure less than 90 or more than 90 with maintained by the vasopressors, with absence of hypovolemia and sign of hypoperfusion like cold, sweated extremities, oliguria, altered mental state, metabolic acidosis, defined as cardiogenic shock. It should be treated in CCU or ICU. With delayed treatment, cardiogenic shock initiates systemic inflammatory response, leading to multi-organ failure. The second classification is depending on the precipitating factors. There are acute coronary syndrome, arrhythmias like tachyarrhythmia or bradyarrhythmia, uncorrected hypertension, concurrent infection. Non-compliance is the main cause. Study have shown the topmost cause for acute decompensated heart failure is non-compliance to the medicine, excessive use of toxic substances, and some drugs, calcium channel blocker, steroid, NSAID, that can precipitate the acute heart failure. COPD, pulmonary embolism, metabolic hormonal disorders, stroke, acute mechanical cause like rupture or acute MR or AR, additional acute causes like pericardial effusion, myocarditis, all can precipitate acute heart failure. So the clinical, so this is important. Another classification that is very common, 2 main symptoms, congestion and peripheral sinus symptoms, congestion and peripheral hypoperfusion. So most frequent is the congestion and the rare one is the hypoperfusion. This approach divided into 4 groups, okay, and it has got prognostic value as well. What are these? 25% are warm, okay, the peripheries are not cold, okay, and dry. So they can be treated on oral therapy only. Another group, cold and dry, like peripheries are cold, there is hypoperfusion, but the chest is clear. So they can be given a fluid challenge as well, okay. These are only 5%. 50% of the patients are warm and wet, okay. The peripheries are warm, but there is congestion. So they need diuretic, vasodilators, and ultrafiltration if required. And 20% are cold and wet. They are hypoperfused as well as they are congested. The lungs are congested, blood pressures are low. These are the ones which have a bad prognosis. Okay, they need inotropic agents, vasopressors, diuretics. Okay, so this is important classification. We have to risk stratify. We have to classify the patient at the bedside when it comes to the emergency. So management, it depends. First hour management, that is important, very important. If you need to start the treatment as early as possible. So high risk complication occurs during the first hour. So time to treat approach, as just like in acute coronary syndrome, you have to start the treatment as early as possible. And early pre-hospital treatment is associated with lower mortality. De novo heart failure patient develop chronic heart failure, so ischemia should be treated early. So you can prevent the patient to have a structural abnormality. Okay, so by treating them, you can prevent them to going into the chronic heart failure. Should be rapidly transferred if you don't have a specialty. like 24 hours cath lab or expertise in heart failure, you should transfer the patient to a cardiology department or emergency department with CCU, ICU, or expertise. This is a beautiful slide. I would say it's a summary of my presentation today. So first, our treatment. If the patient is cardiogenic shock, you need to treat accordingly, like inotrops and vasopressor. Respiratory distress, non-invasive ventilation is very important. We'll discuss in my next slides. Congestion should be treated with diuretics and vasodilators if blood pressure allows. Okay, and additional tests you need to do with the ECG imaging and everything. Then we can divide the management into first day and first week. Okay, we'll discuss. So immediate concomitant investigation, diagnostic test, and pharmacologic and non-pharmacologic should start it immediately. Everybody knows respiratory rate is important, orthopnea. These are the signs and symptoms of acute heart failure. Accessory muscle use, cyanosis, pulse oximetry is very important. Audible rails, systolic, diastolic blood pressure. You need to see all these signs and symptoms in patients with acute heart failure. Different scenarios. If the patient is in his respiratory failure, he needs assistance. Okay, it should be respiratory, immediate respiratory and cardiovascular support should be transferred there. There should be, you need to have a multi specialties. If a MI, you should be shifted for the acute STEMI protocol. You have to follow. If cardiogenic shock, you need to shift to the ICU or CCU. ECG, most important, STEMI. If the patient is in a STEMI with a ST elevation MI, you need to transfer the patient and treat accordingly. The ECG can give you clues regarding the arrhythmias, tachyarrhythmia, bradyarrhythmia, white complex. Okay, so ECG is the important tool for the diagnosis as well as the management. Bedside thoracic ultrasound, that is very important. Why? Because heart failure symptom, patient can come with a non-cardiac causes of heart failure as well. So ultrasound is useful diagnostic tool for the signs of interstitial edema. That is okay, and it has given, it can give you this B-line quantitative assessment. If it's less than 5, the interstitial edema is absent. If it's more than 30, severe pulmonary edema is present. Okay. Other thing, chest X-ray, most common modality used. Like it can tell you pulmonary venous congestion, pleural effusion, interstitial alveolar edema, and cardiomegaly, which are all part of acute heart failure. And sensitivity is limited, like 20% of the patient can have a normal chest X-ray. Okay, so you don't have to rely only on chest X-ray. Lung ultrasound may be more sensitive and time-saving modality in detecting interstitial edema. So, nowadays in advanced treatment, this should be present in every emergency to differentiate the patient with acute pulmonary edema and other causes for heart failure and heart failure symptoms. Okay, etiology of dyspnea like pneumonia and infection can be diagnosed with X-ray. Echocardiography is very important, especially not every cases, but if the patient is in cardiogenic shock or acute life-threatening structural or functional abnormality. In other cases, it may be performed later during hospitalization, not urgent. But remember, cardiogenic shock and acute, if you are suspecting a life-threatening functional cardiac abnormality, echo is important. Early should be pursued in de novo heart failure patients and those with the cardiac function is unknown. If you don't know the cardiac status, echo can give you a clue. CT is not particularly relevant in diagnosing acute heart failure, but it is important if you are suspecting a pulmonary embolism. It's a gold standard. So breathing near impossible. Or 2 minutes? Okay, I'll try to complete. So BNP is very important, in emergency department, in all patients with acute dyspnea and suspected acute heart failure, net uretic peptide is very important to diagnose as well as for the prognosis. Okay, it has high sensitivity and it has ruling out. If BNP is negative, you can rule out acute pulmonary edema, okay, and acute heart failure. And if it's normal, like heart failure diagnosis is less likely. Okay, it has got a prognostic value as well. Cardiac troponins can be done for the ischemia. These are the other tests that can be done, for the renal function, the liver function because of the congestion, and glucose, CBC,
TSH, American and European Heart Society, they recommend thyroid for the hypothyroid as well as hyperthyroid. Both can precipitate acute heart failure. Blood gases that are important for, if you are suspecting acid-base imbalance in COPD, it can be done. And even venous blood gas can be done to detect respiratory or metabolic acidosis. These are the few biomarkers, but they are not still in practice. Research is going on. So treatment, initial therapy is with the oxygen therapy. If saturation is less than 90, you need to oxygenate. Hyperoxia, you have to be very careful. Every patient we put on the oxygen. You need to see if the oxygen is maintained. You don't have to give, because hyperoxia can cause coronary and cerebral reduce the blood flow to the coronaries as well as the heart. Non-invasive ventilation is very important in the respiratory distress. I'll go quick. So, CPAP and BiPAP studies have shown, and the European Respiratory Society and American Thoracic Society recommend either of the these modalities in acute respiratory failure if it is occurred due to cardiogenic acute pulmonary edema. Non-invasive, like pre-hospital, even in the pre-hospital, they recommend it should be started even in the pre-hospital settings. And for obviously for the COPD, BiPAP is, but this CPAP have got promising results in patients with acute pulmonary edema. Contraindication, respiratory arrest, and significant instability, vomiting, and patients with these conditions and those who are unresponsive should be intubated. Okay. Diuretics are very important. It's the key treatment for the patient with acute heart failure. I'll discuss the DOSE trial. It has shown greater improvement in diuresis and dyspnea at the cost of transient worsening of renal failure. I mean, so they have compared in the high dose versus the low dose. Okay. So high dose arm of the trial, patients were administered with 2.5 times their previous oral dose. That leads to deranged renal function, but mild renal dysfunction that was manageable. Okay. So DOSE trial was done for patients with acute heart failure, and they have been given furosemide. Okay. So it modify. Let's go. So it can cause hypokalemia, dysfunction, or hypovolemia. That is manageable. Okay, but furosemide is a part and parcel of the acute heart failure management. Ultrafiltration may be considered if not responding to the furosemide. Okay. Vasodilators are the second line of drugs that are important. Should not be given if the BP is less than 90. So nitrates, it acts both as a venodilator and antidilator. It decreases the preload as well as the afterload in patients with acute heart failure. These are the trials which have not promising result, but was done to treat. So see, in acute heart failure, there is no much data. The management is same for the last 15 to 20 years, like diuretics, dilators, as well as the other drugs. So contraindication to vasodilator are shock, acute mechanical complication, and RV failure. Other drugs that can be used, opiates are no more recommended. I mean, other trial have shown that it has increased the rate of mechanical ventilation, ICU admission, and death in patients with acute heart failure. Vasopressor and sympathomimetics can be used, but these registries have shown reduced use of these vasopressor and sympathomimetic drugs. So these should be restricted to patients with hypotension and low cardiac output only. Okay. First day management. So we are done with the first hour. First day management, rapidly, you have to identify the cause, and the ischemia, STEMI, and ischemia have been treated. This is important. They recommend the coronary angiography in all patients with newly diagnosed heart failure. All patients with newly diagnosed heart failure, coronary angiography is recommended. Severe arrhythmia should be treated accordingly, like tachyarrhythmia, bradyarrhythmia. Acute mechanical causes should be treated surgically. Okay. And immediate echo is important, and urgent surgical and percutaneous repair. Pulmonary edema, we all know, should be treated with thrombolysis, catheter-based approach, or surgical embolectomy. Infection should be significantly elevated procalcitonin is useful, and it predicts the worst in hospital outcome, increased 30-day mortality irrespective of heart failure,
severity. So if you are suspecting infection as a precipitating cause, procalcitonin is a good tool to, for the prognosis as well as the management. Rapid detection can prevent adverse outcomes, So you have to find the precipitating cause. Okay, all right. So I'm bypassing these slides. So multidisciplinary care is very important. As you have treated the patients with the acute heart failure, these you need to start these the oral heart failure therapies. That is for the chronic heart failure, like beta blockers. Important is discontinuing beta blocker has shown significantly increased risk of acute emergencies. Okay, so before discharge, the patient should be on a guideline directed medical therapy. Okay. Transition to oral diurotherapy should be initiated and evaluated. Patient should be hemodynamically stable and decongested before discharge, and should be started on heart failure therapy 24 hours before discharge. Okay, that is very important. So follow-up should be recommended, that and self-care education, that is very important. Let me show you a study. I'm not going in. Non-compliance should be addressed to the patient. Okay, and this study is important. Okay, this is important. First, our individual teaching session with the nurse educator to standard discharge decrease the risk of readmission and death, increase compliance, and reduce cost of care. So, discharge is very important, and you need to counseling. Patient counseling is very important. So this slide I have put it. We have to focus on this stage A of heart failure. Stage A is the patient who are having hypertension, coronary artery disease, and diabetes. So preventive cardiology. If we restrict the patient at this stage, we can reduce the evidence of heart failure, and heart can become happy. So with this slide, I would like to end my presentation. Thank you very much.
Nice presentation. This is going to summary about the next speaker for Ahmed Musa. He had a master's degree in cardiology, and he worked as cardiology specialist in our hospital. We will talk about coronary disease. Sorry.
السلام عليكم. السلام عليكم. السلام عليكم. السلام عليكم. مين برضو؟ بسم الله. We are talking now on acute coronary syndrome. It includes STEMI, SCT segment elevation myocardial infarction, non-SCT segment elevation acute coronary syndrome. It includes unstable angina, non-SCT segment elevation myocardial infarction, and sudden cardiac death also involved. We are talking about facts, risk factors, diagnosis, differential diagnosis, management, and precautions, red flags, then take home message. Facts: coronary vascular disease. They are a major risk cause of death worldwide. It represents 31% of total deaths. Cardiovascular disease, number one cause of death worldwide, and coronary acute coronary syndrome represent half of this number. It includes the 37% total cardiovascular disease. في a lot of studies done. This study includes 6,000 patients, and it shows that STEMI patients include 39% of total acute coronary syndrome, and non-ST segment elevation acute coronary syndrome represents 61%. Acute coronary syndrome in Gulf area, it come and start in lower decades than Western countries. It mostly appear in the fifth decades in comparison to developed countries. It appear in sixth decade. For these facts, we will. There is a lot of improvement nowadays due to following of recent guidelines and treatment and medical professional education. Therapeutic recommendation for acute coronary syndrome will significantly decrease the cost, morbidity, and mortality benefits. في a lot of risk factors that you most of us know it, and it is not separate risk factors. It is related to each other. It includes age, diabetes, hypertension, smoking, obesity, previous history, family history, and previous coronary artery disease included also. There is few modifiable and non-modifiable risk factors. Non-modifiable risk factors include age, like old age, genders, genetic factors, race, like South Asian rich, highly indicated. The modifiable risk, there is modifiable risk factors that we can manage in meticulous control blood pressure, stop smoking, and meticulous control of diabetes, decrease body weight, and lifestyle modification, food diet, and cholesterol level. A new term called risk enhancers by American Heart Association and American College of Cardiology. This increase the rate of acute coronary syndrome prevalence, include family history of acute patients that has coronary artery disease, first degree relative in men less than 55 years, and female less than 65 years. Elevated lipid biomarkers like persistent elevated triglyceridemia and high lipoprotein A and lipoprotein B, primary hypercholesterolemia, especially LDL cholesterol more than 4.1 millimole. High risk race like South Asian has higher rate in prevalence in acute coronary syndrome like Bangladeshi patients. We all met in our department has risk factor higher than other risks. Metabolic syndrome including obesity and increased waist circumference, male and female, and elevated blood sugar and blood pressure, increase CRP, chronic kidney disease, especially whose GFR less than 60, chronic inflammatory disease, rheumatic rheumatoid arthritis, systemic lupus, and AIDS, psoriasis, high prevalence also. Premature menopause, it means by in female less than 40 years. Eclampsia include. Diagnosis of acute coronary syndrome, it includes many factors, many steps. We will start with history, physical examinations, in ECG, electrocardiogram, biomarkers, imaging, and atlas. Coronary angiography is a gold standard test. History, all of us know about typical chest pain, that diffuse external chest pain, that constricting burning sensation, compressing in nature, but a few cases came with atypical presentation and atypical chest pain, like angina equivalent, shortness of breath due to left ventricular diastolic dysfunction, usually associated with autonomic manifestation like sympathetic or parasympathetic activities, sweating, nausea, vomiting, palpitation, dizziness. New onset angina occur in 20% of patients. May also burden diagnosis of unstable angina increase. Patient has stable coronary artery disease and there is worsening of the condition, increased frequency in the pain, severity, duration, and lethal activity. Post-infarction angina, that chest pain occurring within 1 month after MI. We will, in history, also should take ask about risk factors, previous MI, previous diabetes, hypertension, renal insufficiency, family history, peripheral artery disease, and male and older age included. Physical examination, most of cases may be physically normal. Patient may be hemodynamically stable, blood pressure, pulse, everything may be normal, but a few cases can be appear present with left ventricular failure, congestion or apnea, palpitation due to arrhythmia like ventricular tachycardia or pseudoventricular tachycardia, atrial fibrillation. We also should differentiate during we ask question to exclude other causes of chest pain like pulmonary embolism, aortic dissection, pneumothorax, pleurisy, pericarditis, cardiac neurosis, psychological problem, and there is musculoskeletal chest pain with nuclear tenderness as usual. ECG. Few patients came with normal or initially non-diagnostic ECG. ECG can differentiate between types of acute coronary syndrome, SCT elevation, myocardial infarction, or non-SCT segment elevation acute coronary syndrome. SCT segment depression, SCT and the T-wave changes occur. SCT segment depression, T-wave inversion, transient SCT segment elevation, coronary vascular occur. Maybe patient present with arrhythmia, either atrial fibrillation, pseudoventricular tachycardia, ventricular tachycardia, or extrasystoly. ECG should be done in the within 10 minutes from first medical contact, and should be repeated after 15 to 30 minutes interval during the first hour of first medical contact. Here we can differentiate between STEMI types with different types. It include left ventricular walls affection or right ventricular affection. Left ventricular affection types of STEMI differentiate according to from ECG reading. We can differentiate it. If ST elevation occur from V1 leads the V1 to V6, it is anterior MI. Anteroseptal, it include leads from V1 to V4. Lateral STEMI include leads V5, V6, lead 1, and AVL. High lateral include lead 1 and AVL. Anterolateral it leads anterior leads versus V1 to V6, including 1 and AVL. Inferior leads include leads 2, 3, and AVF. Posterior leads it should be appear in the regular 12 lead ECG as tall R wave in V1 and V2, and ST segment depression in V1 and V2 should be confirmed by change the position of leads to posterior axillary line and posterior scapular line. It is called the V7 and the V8. RV infarction, usually we did right-sided ECG and changed the chest leads to right side in patient with came with inferior myocardial infarction with hypotension. Biomarkers, it is the key to diagnose and differentiate between the causes of acute coronary syndrome and chest pain. Cardiac troponin, high specific troponin, I and T and CK may be highly specified markers. Negative cardiac high specified cardiac troponin has more than 99% negative predictive value of acute MI. Unstable angina has negative cardiac biomarkers. This will present with chest pain, maybe ECG changes. Non-ST segment elevation myocardial infarction, non-STEMI, has positive cardiac biomarkers. STEMI came with positive biomarkers, and these biomarkers indicate that there is myocardial necrosis. There is myocardial injury. Diagnostic criteria for acute MI according to ESC guidelines, European Society of Cardiology, American Cardiology, American Heart Association, and American College of Cardiology. It represents acute MI definition. It is rise or fall of cardiac biomarkers, especially cardiac troponin, more than 99 percentile of upper reference limit, will associate with one of the following. Symptom of ischemia, most common cause, most common presentation of chest pain, new ST segment elevation, a new pathological cue appear in ECG. في imaging evidence, echocardiography evidence of myocardial loss of viability, like wall motion abnormalities in the echocardiography report. Identification of intracoronary thrombus by during coronary angiography or after this during autopsy. Also, في MI related to cabbage, troponin should be more than 10 folds of the upper limited normal range. BCI related MI, it should be troponin level more than 5 times of the upper normal limit. As during manipulations, during BCI and the cabbage, troponin usually elevated, but not so much like MI. Imaging is highly beneficial in patients with acute syndrome since presentation. Chest X-ray can give idea about patient there is cardiomegaly, ischemic cardiomyopathy for previous attacks due to hypernating myocardium. Transthoracic echocardiograph can show regional motion abnormalities or mechanical complication during STEMI or non-STEMI, like mitral regurg and ventricular septal rupture. CT coronary angio is good negative test, and if there is a lesion not high specified for detecting of highly significant lesions, coronary angiography is the gold standard. Myocardial perfusion imaging includes thallium and technetium scanning active care and shows the viability of myocardium. Management of acute coronary syndrome. We should first initial evaluation. All patients suspected for acute coronary syndrome and has chest pain should be admitted to emergency department for to be seen by qualified physician. Delay the only permitted delay for doing ECG for patient with chest pain less than 10 minutes. We should do risk assessment and risk monitoring for the patient. We should evaluate vital signs, ABC, blood pressure, vital signs. The sedative drugs can be given to patients with agonizing chest pain like morphine and glycine IV. Step 2, medications for first aid in patient with acute coronary syndrome, and later can be used for long-term usage during patient with coronary artery disease. Anti-anginal medication include nitrate. During acute coronary syndrome, we can use lingual nitrate or nitroglycerin patch, nitroglycerin IV infusion. Beta blockers, especially oral medication like bisoprolol, metoprolol, carvedilol are evidence-based to decrease mortality and morbidity and improve the cardiac function, decrease hospitalization. Calcium blocker alternative to beta blocker is contraindicated, like patients with bronchial asthma. Verapamil diltiazem is one of our most options. Anti-ischemic medication, it includes antiplatelets and anticoagulation. Antiplatelets include oral and parenteral. Oral must use load aspirin and Plavix. Aspirin, clopidogrel, loading ticagrelol. The first loading dose, then maintenance dose. Aspirin loading dose 300 milligram to 325 milligram chewable tablet. Then we will continue maintenance at 75 to 150 milligram VOD. Clopidogrel loading dose 300 milligram. Patient not planned for intervention. Then maintenance 75 milligram VOD. Ticagrelol loading dose 180 milligram, 2 tablets. Then given BID 90 milligram BO. Prasugrel is used due to more side effects mostly used in patient planned for intervention. Parenteral antiplatelet, limited usage, eptifibatide and fluvoxamine, used mostly after cath lab, patient with high thrombus burden during coronary angiography seen or patient planned for coronary artery bypass graft and stopped 4 hours before CABG. Parenteral anticoagulation it is important and to decrease the progression of thrombosis and extent of thrombus in the arteries as the patient has hypercoagulable state. Heparin IV recurrent pulses can be given, especially patient with during BCI or before BCI, or heparin IV infusion therapeutic dose with target BTT guidance according to ACS protocol. Target BTT or usually from 60 to 80 seconds. Enoxaparin 1 milligram per kilogram BID can be given for therapeutic. Fundabarinox, this will be given once daily 2.5 in patient not planned for BCI. Patient will take conservative medical management in CCU. Heparin also recommended in patient with renal impairment, renal failure, and decreased GFR. These inhibitors, the angiotensin receptor. This inhibitor is useful to improve the function, decrease mortality and morbidity, decrease the function size of the patient with MI. ARBs, valsartan, losartan, temsartan, statins used in acute coronary syndrome for dyslipidemia, and it acts as anti-inflammatory and stabilization of atheromatous plaque to decrease the extension of atheromatous plaque rupture. Management of STEMI, early perfusion is the most important issue, and time is a muscle. Every minute passed, you can save myocardial cell from this. Our aim to prevent this, to extend the myocardial damage, improve the patient chest pain. We have 3 strategies: primary BCI, pharmacological thrombolytic therapy, pharmacoinvasive approach combination of BCI thrombolytic therapy, then early intervention by BCI planned from 6 hours to 24 hours of BCI. Guidelines recommend primary BCI recommended when it is available within 2 hours. If not available within 2 hours from diagnosis and ECG, finding of MI, fibrinolytic therapy should be given within 12 hours. Class 1A recommendation. Fibrinolytic therapy can be given in patient reperfusion study as early as possible, and the agents recommended for fibrinolytic therapy including tenecteplase, alteplase, retiplase. This is the 3 ways we should do. Primary BCI is the first option if available within 2 hours. Pharmacological reperfusion, it includes thrombolytic therapy, fibrinolytic therapy, alteplase, retiplase, tenecteplase. Pharmacoinvasive, to save time, we can use it during Hajj due to out of numbers, maybe a cath lab not available at a patient may be busy. We start thrombolytic therapy and patient can be shifted after from 6 to 24 hours from thrombolytic therapy to decrease bleeding risk. If we give thrombolytic therapy and failed, we should do rescue BCI within 2 hours. We should shift it quickly. ESC STEMI guidelines, reperfusion strategies. From 0 hours, it is symptoms of chest pain. First 3 hours, we will do primary BCI. If not available within 2 hours, we give fibrinolytic therapy and with equal results. From 3 hours to 12 hours, primary BCI also preferred than fibrinolytic therapy with more successful results of care. After 12 hours, the only option is primary BCI.
Summarize this.
Time is precious. Time interval is very important. ECG should be done within 10 minutes from first medical contact. The BCI should be done within 120 minutes from first medical contact. If patient will be transferred, if the hospital is presenting has BCI capability, it should be less than 60 minutes. Pharmacoinvasive approach is new era. It includes thrombolytic therapy. Then later we will give thrombolytic. Then we will do primary BCI. Alteplase, retiplase, tenecteplase. The preferable one is tenecteplase, high specified to dissolve fibrin meshwork during fibrinolytic therapy. So it is one bolus. Retiplase, 2 boluses, 30 minutes in between. Alteplase we will give IV bolus or then IV infusion. Why to do pharmacoinvasive approach? Thrombolytic therapy prevent the artery is totally occluded. When we give thrombolytic therapy, it only dissolves the thrombus. The lesion is still there is a stenotic lesion, atherosclerotic lesion, close the artery. So the lesion may be mostly more than 70%. So invasive approach will improve the anatomy of the artery and decrease the stenosis and reoccurrence of thrombus again on the lesion. Primary BCI preferred at this carpal artery reopening mostly. Fibrinolytic the advantage of thrombolytic therapy, it is faster to deliver than primary BCI. It should be given within 10 minutes to 30 minutes of diagnosis of MI. Primary BCI also its problem has the reperfusion injury and vessel wall endothelial injury. Thrombolytic therapy disadvantage has a risk of intracranial hemorrhage, especially in old age. Invasive strategy in non-SCT segment elevation, acute coronary syndrome, immediate invasive strategy within 2 hours. In patient with resistant severe chest pain with high risk factors, early invasive within 24 hours. Invasive strategy less than 72 hours. Selective invasive surgery in patient asymptomatic, stable, no ECG changes or elevation or markers. Revascularization, the total revascularization therapy occur by heart team opinion and discussion. BCI or cabbage. BCI preferred in patient with single vessel disease, 2 vessel disease, multi-vessel disease, left main artery disease in selected patients. Coronary artery bypass graft is preferred in patients with left main disease, multi-vessel disease, 2 vessel disease including proximal and ostial left anterior descending artery. If the patient is planned for other surgery, open heart surgery like valve replacement.
Can you just conclude your presentation?
1 minute. Precautions red flag. When we give nitrate in the ER, we should ask well about the patient history. Maybe take phosphodiesterase inhibitor like Viagra, sildenafil, tadalafil. Analgesic therapy non-steroidal is contraindicated, except aspirin, as patient will may cause to him silent MI or free wall rupture of left ventricle. Beta blocker, IV beta blockers is contraindicated patient with shock state or patient in acute pulmonary edema. Calcium channel blocker like nifedipine has a flex tachycardia, so it is not preferred unless added beta blocker. Fibrinolytic therapy not recommended, and because harm patient with non-SCT segment elevation myocardial infarction or unstable angina that has initial prosthrombotic effect may transfer patient from non-STEMI to SCT segment elevation MI. Take home message. MI patients is a critical emergency and the clinical outcome improve when good education to the team and following recent guidelines. Pharmacoinvasive strategy recommended if not primary BCI not done within 120 minutes. Primary BCI gold standard in performing less than 2 hours from first medical contact. Thank you.
Thank you, Dr. Ahmed, for your time for the discussion. Now, for question, welcome. Do you have any comment? Okay.
Thank you very much. We was just before having position, which is supposed to be having two important things supposed to be delivered for them. For you, Ahmed, and your syndrome, try to follow pharmacoimplicit approach. Not all the patients are handled as particular syndrome. So all of the which is working with us, so supposed to be know very well pharmacoimplicit approach, like PCI, if the patients cannot be do as them so. This is an important message for all our day. Meaning, if therapeutic therapy doesn't shift hospital will just end up but if your patient can be good for PCI, it is a good decision. Right? Secondly, importantly, if you have a lot of therapeutic therapy, choose more fiber-specific therapeutic therapy start. Right? Consider, especially in the mechanical application for primary function. Why? In order to most of them have pain, and the have pain and the to gain by acute heart failure due to mechanical. So put it in your hand as a mechanical application. One of priority to put into consideration in patient mechanical complication needs re-rupture. Pre-war rupture, MR rupture, importantly, and second rupture. Most of the Hajj time is over the 26th way. Thank you very much.
Thank you, Rahman. Any questions from the audience?
And this all, I don't know if the pathway for transfer the patient to the screening is very clear to them, or on the hotline they are familiar with the hotline available to transfer patients who presented in the screening to the lab. Any comment from the ER? They know this pathway, hotlines, and how to transfer patients at lab during the Hajj season. Anyone from the ER here? You know the pathway, it's clear for you, and the hotline is working, and no comments for. No more question. We can conclude. This is the end of the second session, and we have the lunch will be provided at the swimming pool, and the entry will be for the ID card of the conference. And please be here at 1 p.m. sharp after Dhuhr, inshallah. And lucky to have you on the Shukran.
نعم. ها؟ لا لا بعدين ايوه.
يعني مفيش اسامي ده
Bismillahirrahmanirrahim. Welcome back to our conference lecture. Next speaker will be Dr. Abashar, board certified in medicine, and she will talk about the transfusion and HCG.
أشياء. طيب الكمبيوتر. Hello, good afternoon. This is Bushra Al-Qurashi, an internal medicine board certified. It's my pleasure today. Okay. It's my pleasure today and an honor to be a participant in Al-Hajj conference and to be a presenter in such event. I'm here today on behalf of our great hematology department to present a small talk about the clinical use of blood component during Al-Hajj season. We will go through a blood component transfusion indication in this small mini talk, and we will talk about the common reaction that's happened during the transfusion. First of all, we will start by a blood transfusion record. This record is coming from our blood bank at النور hospital. This record is mainly related to the blood component transfusion, the requested of blood transfusion disposition among our specialty at النور hospital, and about the indication for this blood transfusion. We'll start by Hajj season in 1440. The main blood component disposition was requested by ER by 28%. It was followed by internal medicine by 18%. Internal medicine department, it's involving the cardiology, the hematology, nephrology, neurology, and the hemodialysis unit. Followed by general surgery by 15%, surgical subspecialty by 14%, orthopedic surgery by 11%, critical care unit by 10%, and day care unit by 4%. Regarding the indication for these blood transfusion requests, we found that 38% of these blood requests was done for emergency cases. These emergency cases is cover the life-threatening condition and cross-match blood transfusion in addition to emergency surgery. The rest of these blood product was requested only for elective cases by percentage of 62. We'll go to Hajj season during 1442, which is unfortunately was affected by pandemic of coronavirus disease. Still, ER on the top of our list for as the most common disposition of blood product by 41%, followed by internal medicine by 21%. Then we will find the surgical subspecialty by 14%. This surgical subspecialty, it's including the vascular surgery department, plastic surgery department, ENT department, and other surgical subspecialty department. Followed by the orthopedic surgery by 12%, general surgery by 10%, and critical care area by 7%. Regarding the indication for these blood products, we found around half of these blood products was requested for emergency causes by 43%, while the other blood product requested was only considered for elective cases, either to hemoglobin as either for pre-op preparation and optimization of hemoglobin level. This is an overview regarding the blood donation during the Hajj season. In 1442, we only have 407 units came through blood donation, while in 1440, we have only 304 units came through blood donation. There is a huge gap between the blood donation and between the utilization of blood products mainly in our hospital during the Hajj season. We'll go to the next aspect of my talk. It's about the blood component. In this talk, I will talk about the blood component in general and indication of each blood component transfusion and the complication related to these transfusions. There is 5 main components of blood. Including the plasma, red blood cell, white blood cell, platelet, and cryoprecipitate. Each unit of whole blood is equal to 500. 350 ml of one unit, it represents the packed RBCs, while 200 to 30 ml of these units represent the fresh frozen plasma. Platelet is equal to 50 ml of 1 unit, and cryoprecipitate, it's only represent 10 to 20 ml of whole blood in each unit of blood. Now we'll talk about the first component of blood, which is the red blood cell transfusion, which is the most utilizing component of blood for transfusion. Red blood cell transfusion are given to treat anemia or to replace loss of blood in case of acute bleeding. The decision of blood transfusion is correlated to the clinical scenario of the patient and clinical status and comorbidities. Based on these issues, we will decide either to transfuse or not transfuse. For patients with hemodynamic stability with no symptoms of anemia, we are accepting to transfuse the patient with blood with hemoglobin level below 7 if we have a failure of treating a patient or to treat the cause of anemia of this patient. Always before transfusing the patient, we have to investigate for the cause of the anemia. There is a major exception for higher threshold for transfusion. These exceptions include symptomatic anemia with hemoglobin below 10, regardless of the level of hemoglobin. So in case of symptomatic anemia, we have to transfuse the patient regardless of the hemoglobin level. In case of acute coronary syndrome with hemoglobin level between 8 to 10, we have to transfuse those patients including unstable angina patients, STEMI and non-STEMI patients with target hemoglobin above 10. In case of trauma or serious gastrointestinal bleeding, in case of chronic transfusion-dependent anemia, such as the patient of sickle cell anemia or thalassemia. Now we'll move to the second element of blood component, which is the platelet. Platelet transfusion is indicated in thrombocytic patients with active bleeding to keep a platelet count above 50,000 per microliter, while in case of central nervous system bleeding, our aim to keep a platelet count above 100,000 per microliter. Other indications for platelet transfusion include febrile patients with platelet level below 20,000 per microliter, stable patient with platelet level less than 10,000 microliter per microliter. We are aiming to prevent consequences of thrombocytopenia, which is related to stimulus bleeding. Also, platelet transfusion indicated in case of massive blood transfusion. In chronic massive blood transfusion protocol, platelet is an important element. It's defined by transfusing the patient over than 10 units packed RBC over 24 hours. So the ratio of platelet transfusion in this case will be 1:1 compared with the red blood cell. Also, platelet transfusion indicated in case of heat stroke as a supportive measure, and this is a frequent presentation among pilgrims during Al-Hajj season. Also, platelet transfusion is indicated as a pre-op. It's our threshold is different. It depends on the type of the surgery. For major surgery, our target to keep the platelet count more than 50,000, while in neurosurgery or ocular surgery, our target to keep the platelet count above 1,100 per microliter. Now we'll talk about the plasma transfusion. Plasma product is generally indicated in the management of bleeding when multiple coagulation factors are deficient, or when a specific factor concentrate is not available. There is a lot of indication of plasma transfusion. We'll summarize these indication by mention them. It's also indicated in case of heat stroke, massive transfusion protocol. It has the same idea of platelet transfusion. We have to transfuse the patient to follow the protocol of massive transfusion protocol by a ratio 1 to 1 to 1 of plasma product. Severe liver disease due to lack of coagulation factor production, disseminated intravascular coagulation due to massive coagulation factor consumption, and management of TTP and therapeutic and therapeutic plasma exchange for immune TTP in case of ADAMS 13 deficiency. These are a condition whereas plasma transfusion is not effective. Plasma transfusion is not effective in case of specific coagulation factor deficiency, as in case of hemophilia A, hemophilia B, factor 7 deficiency, or factor 13 deficiency. Plasma product is also not indicated to treat a supratherapeutic INR secondary to over anticoagulation or vitamin K deficiency. Last element of blood product is the cryoprecipitate. So we'll talk about the cryoprecipitate transfusion. Cryoprecipitate is a plasma-derived blood product for transfusion that contain fibrinogen, factor 8, factor 13, and von Willebrand factor and fibrinogen. The indication for cryoprecipitates include trauma, uremic bleeding that's happened in case of that happened as a result of platelet dysfunction in case of advanced CKD, massive blood loss, postpartum hemorrhage, massive transfusion protocol. So in massive blood transfusion protocol, we have to consider to transfuse the patient with platelets, plasma, and cryoprecipitates. Impaired hemostasis in liver disease due to lack of coagulation factor production, inherited disorder that affecting the coagulation factor synthesis, as in hemophilia and von Willebrand deficiency, disseminated intravascular coagulation. Actually, cryoprecipitate is superior than the plasma in setting of DIC, as cryoprecipitate contains less volume than plasma and has higher concentration of fibrinogen. A condition where cryoprecipitate is ineffective, deficiency of factor of coagulation factor rather than factor 8, 13 fibrinogen or von Willebrand factor. Also, cryoprecipitate not used to correct or to overcome supratherapeutic INR in case of vitamin K deficiency or over anticoagulation. Now, just we'll have an overview regarding the transfusion reaction. Transfusion of any blood product can cause transfusion reaction. The most common transfusion reaction include febrile reaction and allergic reaction. The worst clinical situation is the development of acute hemolytic transfusion reaction. In this case, we have to start always by ABC to secure the airway of the patient, to check the breathing and circulation, and to take the vital sign of the patient, to discontinue the blood transfusion immediately, to notify the blood bank and resuscitate the patient with IV fluid. And also we have to record the event. We have to record the time, the date, and the specific clinical symptoms that related to the transfusion reaction. Also, we have to send for a hemolytic workup. This hemolytic workup including LDH liver, reticulocytic count, blood film, and total bilirubin in addition to direct bilirubin beside the basic workup. And it's very important to keep the patient under close observation. There is other transfusion reaction. These transfusion reaction including the transfusion circulatory overload, which is related mainly to large volume or massive transfusion. Also, we have TRALI, which is referred to transfusion lung injury, which is also a life-threatening condition, we have to notify and recognize it in early to prevent further complication. Also, anaphylactic shock can be a complication of blood transfusion. So just as end of my small talk, I have to convey a message regarding the importance of reviewing the indication for each blood component transfusion, and to avoid overutilization of blood components, especially during the Hajj season, due to difficulty of blood donation and providing a donor in this season. Also, it's important just to raise the awareness about the importance of blood donation and among our society, as it has a helpful role in case of emergency cases and life-saving cases. Thank you so much.
For any transfusion component of the blood, just be meticulous to the indication, and you have to look twice for your indication and review your patient very well. Not all anemic patients, they need to be transfused with the blood. Not all thrombocytopenic patients, they need to be transfused with the platelets. Not any minor increase in the coagulation profile that indication for FFP or plasma or platelets. She did a nice presentation. Thank you, Bushra, for this concise presentation, and I have nothing to add.
Thank you, Dr. Hussain, for this comment. Have another question, or we can proceed for the next session. Ms. Rakima will talk about nursing care of unstroke patients. So, welcome.
Yes. Assalamualaikum warahmatullahi ta'ala wabarakatuh. Good afternoon, everyone. My name is Rakima Dimakutagani Alonto. I am one of the clinical instructor here in النور Specialist Hospital. And today I will present to you a nursing care for heat stroke. So we have here, what is sunstroke or heat stroke? It actually occurs when the body temperature fails to regulate its own temperature, and the body temperature continues to rise as high as 105 degrees Fahrenheit or 40.6 degrees Celsius or even higher. Heat stroke is actually considered as a medical emergency. Even with immediate treatment, it can be life-threatening or can cause serious long-term problems. In 1436 Hajj season here in Al-Nur Specialist Hospital, they actually have more admission of sunstroke patients. The number of admitted patients that time was 98 because the temperature reached as high as 48 degrees Celsius. Now this year, according to the National Center for Meteorology that was published by the Saudi Gazette on June 20, 2022, the expected temperature will rise as high as 43.2 degrees Celsius. That is why it is very important for us to educate all our Hajj pilgrims. Now let's go to the different types of heat stroke. We have here the classic heat stroke and the exertional heat stroke. What does it mean by classic? It can develop without exertion when a person is exposed to a hot environment. Usually this is common to younger children and those who are having or underlying chronic medical conditions that may impair the thermal regulations of their body. The next is we have the exertional heat stroke. These are more common to athletes, to military,
And of course, now Hajj season for the Hajj pilgrims. It generally occurs in individuals who engage in heavy exercises during periods of high temperature and humidity. Sorry. Now, who is at risk? Like what I said, Hajj pilgrims are elderly patients or people, athletes. We also have children. We have military. And we also have workers who are working under the direct sunlight. Just recently, the Ministry of Labor and Social Development has enforced a midday work ban. Thus, it states that no one should be working during the midday. It means from 12 p.m. to 3 p.m. It is expected that all workers should not be exposed in the direct sunlight to prevent heat illnesses. And it will stay for 3 months, and it was implemented from June 15, and it will be until September 15, 2022. And then we have here to differentiate what is heat exhaustion and heat stroke. We have here for heat exhaustion, the patient might manifest headache, fatigue, weakness, skin moist or sweating. We also have orthostatic hypotension. When the patient transfers from one position to another, he might be suffering hypotension. We have increased pulse, anxiety or confusion. What are the possible causes? Decreased fluid intake, increased heat exposure, and increased activity. What are the expected management? Salt and water replacement. For the heat stroke, we have here anxiety, skin hot and dry. We have impaired sweating or what we call anhydrosis. It means that the patient lost the ability to perspire. One or more parts of the body parts doesn't have the ability to perspire. And we also have listlessness. The patient might manifest like the patient doesn't care about what's going on in the environment. And then we also have here seizure, delirium, coma, and there can also be an increased pulse and respiratory rate and also hypotension. The management, we have the cooling. You need to let the patient rest, fluid and electrolyte support. Now we have here in my slides are the Al-Noor Specialist Hospital heat stroke algorithm. As you can see here, this is the heat cramps and syncope. If the patient belongs to this one, all you have to do is to follow the following algorithm. Once the patient falls down, for example, you try to assess the patient and you assess that the patients are manifesting all signs and symptoms of heat exhaustion, you're going to do heat exhaustion algorithm. So the first is the temperature is greater than or equal to 39 degrees Celsius, no significant CNS dysfunction. So maybe the patient might just manifest headache or dizziness. And then environmental exposure to heat. The patient has a history of being exposed to the, being exposed to high temperature. And then next, what are you going to do? You're going to remove the patient from heat environment. You're going to hydrate as prescribed. You're going to do cooling for a short time, 20 minutes till the temperature reach to 38 degrees Celsius. What type of cooling measures are you going to do? You're going to, first, if the patient is conscious oriented and able to drink, you're going to provide fluids. And the next part of the algorithm is the question. Did symptoms resolve within 20 to 30 minutes? If no, what are you going to do? You're going to activate heat stroke algorithm. If yes, then you're going to admit or discharge the patient based on the criteria. Then let's go to once the symptoms did not resolve, it means we need to activate the heat stroke algorithm. So this is the heat stroke algorithm. It means that the temperature is 40 degrees Celsius equal or higher than 40 degrees Celsius. There is CNS alteration. The patient might be what? The patient might be confused, might be restlessness. And then we also have anhydrosis, inability to perspire. And we have large environmental heat load. It means that the patient spend more time outdoors. That's why the patient absorb more load of heat. And then what are you going to do? Of course, you're going to address the airway, breathing, and circulation. You're going to remove the patient from the heat environment. you're going to remove the clothes and you're going to begin the cooling measures. For the cooling measures, we have two types of cooling measures. We have what we call aggressive cooling measures. The aggressive cooling measures, you are going to apply ice pack on all parts of the patient, in the groin, in the axilla, and also in the neck. Now, the disadvantage of aggressive cooling measures is that it can cause shivering that can trigger the spike of the temperature, and also it can cause peripheral vasoconstriction. The second type, which is the one we are using here, is what we call the non-aggressive cooling measures, or we have the slow evaporative technique. In this slow evaporative technique, you're going to remove the clothes of the patient, you're going to spray warm water, and then you're going to expose the patient in an electric fan, okay, to dry air. And then it will facilitate, inshallah, cooling. And once the patient reaches the temperature of 39 degrees Celsius, you have to stop the cooling measures. Why? To prevent shootout, okay? Because per evidence base, once the cooling measure or cooling process started, it went down, it's either it will drop a little or it will shoot out a little. So that's why during this cool process, it is very important to monitor the vital signs of your patient. You need to monitor for the temperature within the first 3 to 4 hours of cooling measures, okay? And the most accurate in measuring or checking for the temperature of the patient is via rectally, not unless it is contraindicated to the patient. Then we have to ask the physician which for the alternative. Okay, and then next is we have the hydrate measures. The hydrate measures is actually refers to the type of IV fluid being prescribed by the doctors. And then the core temperature monitoring, what does it mean? That's what I said. You're going to monitor the temperature of your patient from 3 to 4 hours during the cooling process to prevent shootout. Because as per evidence base, that the patient can there can be a recurrence of hypothermia or hyperthermia. Then you're going to continue cooling till the temperature reach 39 degrees Celsius. And then we have the chest X-ray, CT brain without contrast. Why does we need to do the CT brain? Because according to them, there is this gray matter in the brain that is actually a marker to determine if there is a brain damage going on due to heat stroke. And then we have ECG, electrolytes, because as what is shown before, that there will be a depletion of sodium and potassium once the patient is on heat stroke, and also liver function test and renal function test. And check urine for myoglobin. Once the patient is stable enough and fit to be transferred out of the department, then it's either the patient will be admitted. And you're going to follow complication and education of heat-related illnesses. And then the next slide, I'll be showing you the heat stroke unit of Noor Specialist Hospital. Okay, this is it. As you can see, this is the bed. It has a lot of holes. This is where the water will came. It will spray. And then this is the old bed before. This is the electric fan. Yeah, that's the narration. Yeah. And that ends my lecture. Thank you.
So the next speaker is Dr. Hassan Hausawi, who is the result about community emergency activity.
Other points. Okay. Assalamu alaikum. Good afternoon. First of all, I want to thank you for having me. I'm Hassan Hafsawi, board certified otolaryngologist, working as a specialist here at the Nord Hospital. Today, I'm going to talk briefly about common ENT emergencies that you may face during Al-Hajj season. Okay. In this lecture, I'm going to focus on the clinical features of these conditions, how to approach these patients when you need to consult ENT for these conditions. I'll start with the ear disorders. If you encounter such a patient who presented with auricular swelling, especially if it's preceded with history of trauma or elderly individual who is in blood thinners, you need to call the ENT immediately. This is auricular hematoma. The problem with the auricular hematoma, it compromises the blood supply to the cartilage of the ear. Later on, it may result in permanent ear deformity. This is why such conditions need to be managed immediately by incision and drainage and then putting compressive dressing. Temporal bone trauma. Temporal bone trauma, it could be the patient may present as isolated temporal bone trauma, usually due to a blunt head injury, or it could be part of multiple body trauma. So, clinical features of temporal bone trauma, this is discoloration behind the ear. It's called the battle sign. If you do otoscopic examination, you will find blood behind the eardrum, which is called humus tympanum. If the patient awake, the patient may report dizziness, hearing loss, or ear discharge. It is preferable also to check the facial nerve for the patient, as long as the patient is awake. So if you encounter a patient or a case of temporal bone fracture, stabilize the patient first. Try to assist the facial nerve before the patient's going unconscious or for intubation, or the CT temporal bone, and keep the ear dry to avoid the infection. This is CT temporal bone. There are different types of temporal bone fracture. It could be longitudinal, could be transverse. Longitudinal coming with the axis of the temporal bone. Transverse is parallel with the temporal bone. It could be mixed, both longitudinal and transverse. The most important sequel of temporal bone fracture is the facial nerve weakness, the facial nerve paralysis. It can be immediate. It can be found as if the injury was found very early. In that situation, the patient needs to be treated with steroids for at least 2 weeks if it is not contraindicated. If the onset was delayed or we don't know the onset of facial nerve weakness, in that situation, we need to refer the patients for nerve conduction studies. And based on these studies, the patient may undergo surgical exploration or not. In case of C-SIF leak, if the patient having obvious leak, manage the condition conservatively, make the head elevated, give the patient stool softeners, cough suppressants, avoid increase intra-abdominal pressure. If you are not sure whether the discharge from the ear is a C-SIF leak or not, you may obtain a sample for beta-2 transfer. Hearing loss in temporal bone fracture, most of the time it's managed surgically later on. Otitis externa. Otitis externa is inflammation of the sternodistal canal. Usually patients with otitis externa present with pain, ear discharge. On examination, you may find erythema, edema, also ear discharge. The treatment of choice will be topical antibiotics, topical drops such as gentamicin or ciprofloxacin. Oral antibiotics can be considered in immunocompromised individuals. Give the patient painkillers and instruct the patients to keep the ear dry. If the patient shows no improvement within 48 hours, refer to ENT. If the patient initially presented with copious, a lot of ear discharge, refer to ENT to do suction in the clinic. If the patient shows very severe form of otitis externa, which is a skull-based osteomyelitis, in which the infection extends toward the temporal bone, the temporal bone, especially in immune-compromised individuals, such as diabetic patients. The patient usually present with history of untreated otitis externa. It may complicate with cranial nerve palsy, especially the facial nerve. In that situation, you need to refer the patient to ENT for proper management. Otitis media. Otitis media is inflammation of the medial ear. Usually, otitis media, it is uncommon to be seen in adult individuals. Actually, it is a red flag. It's found if it is found in adult individuals. It is preferable to transfer refer the patient to ENT so the patients can undergo nasal endoscopy to rule out nasal masses. Usually, otitis media comes with a preceding history of upper respiratory tract infection. Patients will complain of ear pain, ear fullness. If the tympanic membrane rupture, the patient may also complain of ear discharge. In otoscopic examination, you'll find the congested tympanic membrane like this. The treatment of choice will be to give patients analgesics, oral antibiotics. It is preferable to be augmentin. If the patient's allergic to augmentin, you may consider macrolides such as zithromycin. You need to consult ENT if the condition was not improving within 48 hours or if the condition got complicated. By complications, we mean it could be extracranial complications or intracranial complications. Intracranial complications, it could be meningitis, it could be subdural abscess, epidural abscess, intraparenchymal brain abscess. Extracranial complications, it could be mastoiditis, subperiosteal abscess, Biseaud abscess, which is abscess in the sternocleidomastoid muscle. Because the facial nerve it passes within the context of the medial ear, it might get compressed with the infection and become weakened and paralyzed. Thrombus formation in the sigmoid sinus. It may extend into the inner ear, resulting in labyrinthitis and fistula formation. If the patient had otitis media plus any of these features, it may indicate a complicated condition, so the patients need to be transferred to a hospital for proper management. If the patient showed post-auricular hematoma, as in this picture here, this is post-auricular hematoma, and this is protruding ear as a result of subperiosteal abscess. This is due to mastoiditis. This is subperiosteal abscess. If the patient complains of retroorbital pain, it may indicate pityositis, which is inflammation of the petrous apex of the temporal bone. Patients who report vertigo could be due to labyrinthitis or branchial fistula. Otitis media plus facial nerve paralysis also is considered emergency because we need to decongest the middle ear to minimize the pressure to the facial nerve. Patients with intracranial complications, most of the time they report headache, lethargy. Some patients who got meningitis, they may report features of meningitis such as neck rigidity, positive Porzinski and clearing signs. Focal neurological deficit may indicate brain abscess. So patients with complicated middle ear infections usually managed in multidisciplinary manner. ENT, ID, and neurosurgery need to be involved in case of intracranial complications. The patient needs to be hospitalized to be given IV antibiotics. Surgery is indicated in certain complications. Nose disorders. This is a case of nasal bone fracture. If you encounter a patient who presented nasal bone fracture, the most important thing you need to rule out is the septal hematoma. You need to make sure the patient has no septal hematoma. The problem with septal hematoma, the concept is similar to auricular hematoma. The problem with septal hematoma, it compromises the blood supply to the nasal septal cartilage, which results later on in septal perforation and depression of the nose, nasal deformity. So in the ER, you need to make sure the patient has no septal hematoma, and you need you can refer the patients immediately to ENT for initial assessment, or you can refer the patients to ENT within 5 days to be assessed later on after the edema subside to see whether the patients can undergo nasal bone fracture reduction or just needs conservative measure. Epistaxis, it's bleeding from the nose. As you can see in the picture, the nose has abundant blood supply. There are a lot of causes of epistaxis. It could be local, most commonly digital nasal picking, nasal trauma. In the elderly individual, they may present with epistaxis due to hypertension or as a result of having blood thinners being on anticoagulants. When you ever encounter a patient with epistaxis, the first question you need to ask yourself, is the patient stable or not stable? If the patient is stable, whether the patient is having active bleeding or no active bleeding. If the patient is stable, has no active bleeding, in that situation, you can't discharge the patients with appointment to ENT. If the patient having active bleeding, unstable, you may start with the conservative measures. Instruct the patients to pinch the soft part of the nose, to lean forward, apply local decongestants, and then for at least 5 minutes, and then reassess the patient. If the bleeding stopped, that situation you can discharge the patient and give the patient appointment to with the ENT. If the bleeding persists, try to localize the source of bleeding. If you are trained, you can do cautery for the caudal nasal septum. If you can do cautery here, and if the bleeding was from the caudal part and you can't do cautery, we do cautery. If you cannot localize the source of the bleeding, in that situation, apply nasal pack, anterior nasal pack, such as Mirasil or Vaseline strips. Then reassess the patient. If the bleeding stopped, discharge the patient on antibiotics and also appointment with the ENT for at least within 48 hours for the pack to be removed. If the bleeding persists despite putting pack on one side, can't put the pack on the other side and call the ENT so the patients can be admitted and observed in the hospital. In case the patient was unstable, and the patient presented and the patient having bleeding, the patient was not stable, try to stabilize the patient first. Make sure the airway is patent, nothing wrong with the patient's breathing. Take the vital signs, insert 2 large cannulas, give fluid, take blood for investigations, especially blood group and CBC, and call the ENT immediately to help you regarding controlling the bleeding. Also, in elderly individuals, try to lower the blood pressure. That will help a lot. Okay. These are the interior packings materials. The Vaseline strips, it is administered in a lining fashion. Keep both ends out. The Mirasil is administered perpendicularly with the nasal floor. You can apply fusidine ointment or Vaseline to minimize the discomfort. Absorbable packing, such as the gel foam, here, the Surgicel, they are considered for patients with coagulopathies because we don't want to put hard Mirasil pack and then remove it, which may result in rebleeding. So it's preferable to put absorbable packing and keep it there. It will get absorbed by itself. If the bleeding did stop after doing anterior packing, we may need to consider posterior packing. Posterior packing can be done by pre-designed tube, bottom catheter. This catheter inserted all the way toward the nasopharynx. The distal balloon will be situated in the nasopharynx, the proximal balloon in the nasal cavity. It needs to be filled with either saline or air, as indicated here proximally. If you don't have pre-synthesized nasal balloon catheter, you can try with the Foley catheter by inserting the Foley catheter all the way to the oropharynx, inflated, and then withdraw it a little bit back till it lodges in the nasopharynx. So you need to consult the patient having very severe bleeding from the beginning, or the patient was unstable. Acute bacterial rhinosinusitis. It's not an emergency. The complications of acute bacterial rhinosinusitis are considered emergency here. If the patient presented with purulent nasal discharge, that's associated with facial headache, nasal decongestion for 10 days, we can say the patient is having bacterial rhinosinusitis. Or if the patient showed initial improvement and then becoming worse, we can say the patient is having viral rhinosinusitis that got superimposed by bacterial infection. So it is treated by antibiotics, painkillers, nasal decongestants, and normal saline irrigation. You need to consult ENT if the condition didn't improve within 48 hours, or if the patient developed complications. This is anterior rhinorrhea. This is postnasal drip, posterior rhinorrhea. So complications of sinusitis could be orbital complications, could be intracranial complications. Orbital complications could be just confined within the eyelid, as in this picture here. The vision is intact, the eyeball movement tend to be intact in those individuals. Or it could be severe enough to involve the globe, showing chemosis and decreased extraocular movement, vision disturbances. Anyway, if you are having patients with sinusitis showing orbital features, orbital complications, you need to do CT with contrast, and you need to refer the patients to ENT. Regarding the intracranial complications, patients, beside the features of rhinosinusitis, patients may show features of intracranial involvement, such as headache, lethargy, seizures, and signs of meningitis if the meninges got inflamed. In both conditions, patients need to be referred to a hospital, multidisciplinary, and managed in multidisciplinary fashion. ENT, ID, ophthalmology, neurosurgery need to be involved. Ophthalmology for orbital complications, neurosurgery for intracranial complications. The patient need to be hospitalized, given IV antibiotics. Surgery is indicated we usually do sinus surgery for those patients. And for eyelid complication, we don't need to open the orbit, but for orbital collection or intracranial collection, we may need to do eye surgery or brain surgery. If a patient presented with a sore throat, if you do oral examination, find the bulging like this, pushing the uvula toward the other side, this is a peritonsoriasis. It is a clinical diagnosis. You may obtain a CT scan to know to see the extent of collection. Make sure the airway is patent. The patient is not in respiratory distress, and refer the patient to ENT for incision and drainage and IV antibiotic. Paropharyngeal abscess. Patients with paropharyngeal abscess present usually with painful neck mass, showing features of inflammation, edema, tenderness, and you need to obtain CT scan for these patients. Once a collection, CT scan may show hypodense collection with ring enhancement. The treatment of choice would be incision and drainage and IV antibiotic. It is uncommon to see retropharyngeal abscess in adult individual. Usually those individuals, usually it happens in children. Patients may present with sore throat. If you do oral examination, you will find bulging of the posterior pharyngeal wall. Lateral neck X-ray will show increased soft tissue density between the vertebra and their column. More than half of the corresponding body vertebra. The treatment of choice also make sure the airway is patent, refer the patient to ENT for incision and drainage. Epiglottitis, it is very uncommon, very rare to see epiglottitis nowadays due to vaccination. But if a child presented to you with a sore throat, drooling, dysphagia, you need to consider epiglottitis. Avoid manipulation, avoid discomforting the child. Call the ENT so the patient can be examined under general anesthesia, intubated, and swab can be taken and sent for culture. Any patient who presented with history, oral bleeding with history of tonsillectomy need to be referred to ENT, but make sure to stabilize the patient first. Order blood for investigation, CBC, blood group, and cross matching, and consult the ENT immediately. Upper airway obstruction. Stridor is the hallmark of upper airway obstruction. Stridor is the high-pitched sound. I don't know if you heard it before. هنا في فيديو يشتغل ولا الفيديو تشتغل هنا؟ شكله ما. Okay, the stridor is a high-pitched voice. It indicates upper airway obstruction. A patient with upper airway obstruction also may present with shortness of breath. They may present with features of respiratory distress. The most important thing to do if you encounter patients with upper airway, these are the causes of upper airway obstruction in adult individual. Most of the time it's due to a neoplastic condition. It could be due to also vocal cord paralysis. The most important thing is you need to be prepared with such cases. Different personnel need to be involved. ER, anesthesia, ICU, and ENT. Equipments need to be. You need to prepare intubation set, surgical airway set, crash cart, medications such as oxygen mask, dexamethasone, and racemic epinephrine. When you encounter a patient with stridor, the most important thing is to determine the distress level, whether the patient having mild, moderate, or severe distress. Individuals who showed the features of mild to moderate distress you can take a focus history, do a focus physical exam, and then based on that you may order some investigations, and based on the underlying cause, you treat the underlying cause. Individuals who show severe features of upper airway obstruction, such as decreased oxygen sats, diaphoresis, air hunger, lethargy, cyanosis, the patient was unable to talk. Patients with severe features need to be, those individuals, we need to establish a definitive airway. We need to intubate the patient, or we need to establish a surgical airway by tracheostomy or pericothyroidotomy. And then later on, we can dig for the underlying cause and treat it. Blood tracheostomy, you may face cases of blood tracheostomy. Usually patients with blood tracheostomy, they present with shortness of breath. If you do auscultation, you find decreased breath sounds bilaterally. You need to consult the ENT so the ENT can do a fiber optic exam to see the cause of obstruction or to change the tube. You may find cases of foreign bodies. Foreign body battery in the ear, nose, throat. If it's swallowed, if it's aspirated, it's considered emergency. The patient needs to be referred to the hospital to be taken care of. Foreign body insects in the ear considered emergency. All foreign bodies in the nose are considered emergency because the individual may get aspirate these objects. And that's it. These are my references. And thank you for your listening.
Thank you, Professor. So if we have any questions from our audience, please have your hand up. I will ask question. Professor, for your experience, What is the common ENT disease during Hajj season? Is it sore or bleeding, or what is your opinion?
Actually, there was a study done in 2016. Most patients referred as upper respiratory tract infection. Although upper respiratory tract infection can be dealt with in any primary center, but most patients referred due to upper respiratory tract infections. Epistaxis, we see a lot of cases of epistaxis, nasal bone fractures, or as I said, upper airway obstruction also. It is not uncommon to be seen during an Hajj season. Ear trauma, temporal bone trauma, also one of the common cases can be seen. But mostly, according to the study, upper respiratory tract infection, they refer the patients as a case of upper respiratory tract infection, although patients with upper respiratory tract infections can be dealt with in primary care centers.
Do you think during COVID infection now are different cases, how to differentiate between common upper respiratory infection and COVID-related upper respiratory infection? Any advice for the juniors, for the young, how to differentiate into suspect patient is COVID and this other viral infection? Or any criteria or differentiation?
Clinically, it is very hard to differentiate between, because COVID itself it can cause upper respiratory tract infection. So the symptoms may overlap. It's difficult to differentiate between clinically. It is preferable to be cautious if a patient is presented with features of upper respiratory tract infection. Try to obtain a nasal swab for the patient to make sure is it COVID or not COVID. They have very similar presentations. It is very difficult to differentiate clinically between different viruses causing upper respiratory tract.
Fair enough.
Thank you for this presentation. Just I have a question. As the time is a common presenting symptom in the AR, and usually a big rise between neurology and
yes.
the patient with the time AR. I have two questions. We have to consider it as emergency vertigo, and the other issue when how we can differentiate between either central or peripheral vertigo. You refer it for either neurology or radiology.
Excellent question. So if you encounter a patient with dizziness, a patient came to the ER reporting that I'm having dizziness. The first thing, as Dr. Hussein said, could be peripheral, it could be central. We need to take very good history because by history, 80% of times you can reach out to the diagnosis. So we need to know the character of the dizziness. What kind of dizziness? Is it a rotational movement, vertigo? Is it imbalance? The patient cannot keep his balance. Is it lightheadedness, in which the patient المريض يقول أحس إنه راسي ثقيلة. So we need to know what kind of dizziness the patient is having. Besides, we need to ask about associated symptoms. Most of the time, peripheral dizziness that's related to the inner ear, it comes in the form of vertigo that's associated with severe vertigo that's associated with nausea and vomiting. Most of the time, it is related to head motion. And most of the time it becomes weak and fatigued with time. Central dizziness, consider central dizziness or the features in history that may suggest central dizziness. Elderly individual with multiple comorbidities, diabetes, hypertension. Usual central dizziness is not associated with nausea or vomiting. It is not associated with motion. And it is less severe than the peripheral one. After taking good history, you need to perform physical examination. There is there are in physical examination, do head impulse test, do OSCU test, and do also and look for the nystagmus. In head impulse test, instruct the patients to look at one point, to fixate his or her eye in one point, and then try to move the head rapidly. Patients with peripheral disease, peripheral dizziness, they tend to the eye will move. We cannot fixate in one point. The eye will move as the head move, and then he will try to fixate toward the object. Patients with central disease, they tend to have a negative test. If you instruct the patients to look at one point and you move the head impulsively toward one side, the eye will move with the head. But patients with peripheral disease, there will be a catch-up saccades. The eye will move and then fixate. But with central disease, the eye will fixate on the object all the time. Okay, this is the head impulse test. Also, look at the nystagmus. If the nystagmus, by instructing the patients to look at your fingers and to follow your fingers to see the direction of the nystagmus. Usually, the nystagmus is oscillatory movement of the eye. It has a short component, a fast component. We look at the fast component. If the direction having one, if the nystagmus having one direction, if you ask the patient to turn to the right and the nystagmus was in the right, if you ask the patient to look at the left, the nystagmus also directed toward the right. This is unidirectional nystagmus, not changing with direction. In that situation, this is a peripheral disease. But if the nystagmus changed with the direction, if you ask the patient to look at the right, then nystagmus direction was to the right, then ask him or ask her to look at the left, and the nystagmus changed to the left, this is changing direction. Usually it occurs with central causes. Then you may do the eye skew test. The eye skew test ask the patient to cover one eye, and then remove the covering. In central causes, you will find the skew. The eye will move. Upward. So these are simple tests, can help you differentiate between central and peripheral cause. But as I said before, history is very important to differentiate between peripheral and central. Doing these simple tests may help you also to differentiate between peripheral and central. And that's it. Any question?
No question.
Any question هناك أعتقد. خلاص.
Thank you, Mr. Hassan, for your presentation. Thank you all for your listening and attendance. I think we can conclude the first and we'll meet tomorrow, inshallah, at 8. Thank you very much.